Ladies and gentlemen, please welcome Foreign Policy's publisher and CEO, Andrew Solinger, to the stage.
Good morning, everyone.
Good morning.
Oh, and
Am I loud enough? I'll project. Okay. So the theme.
What one health approach by the inclusion of animals? Environment, people, and
Is that better?
Yes.
Okay, very good. The theme, again, Andrew Solinger. I'm CEO and publisher of FP. Thank you so much for those of you watching online for joining us at FP's Global Health Forum at the World Health Assembly 77. This is a very important convening for us. The theme today is a healthier, more equitable future for all. That is a more relevant theme than ever right now. We've got multiple crises facing us. Climate change, political tensions, and big disparities in access to care. And we want to talk through some of those for that right now, especially for the most vulnerable. Having this session during the WHA 77 is a perfect time to address a lot of these issues. So we're so happy to be able together here because we're at a critical juncture when it comes to how we recover the pandemic and are preparing for the next pandemic. Of course, the negotiations for the pandemic treaty got a little sticky last week, and we didn't come to any firm agreement. We're going to talk through that as well. We have Roland Dries with us later. I'll be leading a discussion with him, and we'll talk a little bit about what next steps are and what can be learned from where we are currently. We are going to really think about us as a global community and how we have to work together. A lot of ask me, and if you attended any of our other events in the health space, we had one in New York a few weeks ago, and they asked me, well, why is foreign policy hosting a global health forum? And the answer is, when there's wars all over the place, unfortunately, and a lot that we need to worry about. But this is a critical foreign policy topic, both capital F and capital P, and small f and small p. It crosses borders, it impacts all of us. And 4 years ago, when humanity needed to come together to defend itself against a common enemy, we didn't do so well. And this is when we really took this on as a primary topic for FP. So we do a lot of programming in this space, and it's really important for us. At today's forum, we've got a lot of speakers. Many of you have asked who's speaking today. There's a QR code on the card on your chairs or at your table. You can scan. You'll see the full agenda with bios for all of our speakers. We try and be as ecological as possible and just print that one of those small for you to click through on. But we have policymakers, experts, people on the front lines. They're going to share their insights, successes, folks from government, from civil society, from private industry, the nonprofit and NGO. They're going to also tell us very important things about climate change's impact on health, and ensuring that everyone has access to the medicines they need, and some really interesting conversations that I'm especially excited for, including one on the importance of healthy cities. We'll be joined by the Commissioner of Health for New York City, Ashwin, a fantastic insight into how important that cities are. They're on the front lines. They're sentinels for global health, and we need to involve them critically in this conversation. He'll be able to talk a little bit about that. In fact, he just wrote a piece for FP on this very topic that just published last week. I encourage you to look that up and have a read. And in fact, you can also, there's another code which has access to some of our excellent FP Analytics research content. FP has its own division focused on research and analytics, and you'll see some of that great research there. And you can also click through online. You'll see a link to Dr. Fassan's speech and other content as well. let's see. Most importantly, I wanted to thank our partners, without whom this project would not be possible at all. We're so grateful for their support. It includes OneSight EssilorLuxottica Foundation, Seed Global Health, Viatris, and McKinsey Global Health. I'd like to give them a round of applause and thank them for helping us come together today. Thank you. So we're excited. Let's get going and start with discussion.
To the stage the Honorable Kumbize Kandodo Chiponda for a conversation on healthcare system resiliency in Malawi.
Good morning.
Minister, thank you so much for joining us. I really appreciate your time, and I know you've had a super busy week and a lot going on. You assured me, though, that you still have some voice left after lots of talking, so we're very happy that you're able to share some of that for us.
Thank you.
Wanted to talk about a few things with you, but thought we would start with climate change. It's a threat multiplier. It actually exacerbates risks to global health, and by extension, threats to global security, economic development as well. So it creates dislocation, forced migration, food problems, as well as strained health systems. And that's really something that is, makes it imperative to come up with comprehensive adaptation strategies. We want to talk about Malawi's preparedness and some of what Malawi has experienced in past, what we're doing about that. So maybe we could start with that. Malawi has faced health challenges like cholera and malaria, which have been exacerbated by climate change. Cyclones, flooding, natural disasters, mudslides have also caused disruptions. Can you share a bit more about what it's been like for the people of Malawi in your country and understand the challenges that they're facing?
Thank you so much. Let me express my thanks and gratitude to the organizers for inviting us to give us, room, a platform to share our story, to share the Malawi story on what exactly is happening. So it's a rare opportunity for us to also, develop new partnerships and networking. So for Malawi, it has been a very sad 3 years from COVID 2019, 2021. We have had several climate shocks, public health threats as well. We have had cyclones, Cyclone Annie, Gombe, and the most devastating one was Cyclone Freddy, which hit Malawi on the 11th of March, 2023. It displaced over 2 million Malawians. Also, some Malawians up to now still missing. I can give an example. 10th of March, it was a good day with the sun and everything else. People had dinner, you go to bed. There's this one woman, she had a family of 5. They went to sleep. Everything was okay. It hit at midnight, 11th of March. The next morning, she was all alone. The husband gone, the children gone. All of a sudden, your life flips just like this. The house gone, literally gone, everything gone. So that is the kind of impact we're talking about. Because sometimes when people hear about shocks of climate change, cyclones, they don't have, they cannot put a picture to what exactly is happening. You go to another district in Sanje. I was there the next day, 12. In a village, there's a pregnant woman who cannot deliver normally. Normal delivery, we can do it at home. It happens. Then you go to the hospital after delivery. But this woman, she needed to have a cesarean section. The road washed away. You can literally no access. We don't have helicopters for relief, for emergency rescue. So these are the issues which we are talking about. So I'm saying, how do we assist this woman in the village so that she can still, have access to health services? she can still be able to deliver, even if the the road is washed away, or even if the bridge is gone somewhere. How can I assist that young lady who is supposed to go to the hospital and get refused? Maybe she's on tuberculosis medicine or ART. How do I make sure? Even family planning. Maybe she was due, to go and get refused, but now because the bridge is washed away, she cannot have access. Simple things, but still very, very critical, vital things. How do we sustain health services amidst the climate shocks? We distributed the mosquito nets. We do distribute the treated mosquito nets for malaria prevention. We also give prophylaxis to the pregnant women as well. And for malaria, we have also introduced the malaria vaccine. As of now, I think we have vaccinated over 2 million children. So these are the things which we know we have. We opened the camps, in the camps, we opened the clinics for sepsis. Most of the people who were in the camps, they had lost their health passport, because in Malawi, you go to the hospital, they give you a health passport, so you put your details there. Then with the rains, the mudslide, most of them, the passports, they washed away.
So these are printed passports, you're saying? These are not electronic, and
No.
these are the sole records that these people have for understanding their health history, what drugs they take. They don't even know the name, unfortunately, and they're very complex. I don't know the names of the drugs.
That's the thing. That's the thing. You ask them, are you on a medication? Yes. What kind of medication were you taking? No, it was a red tablet or it was a pink tablet. I understand. Typical village setting, in the rural areas, they don't know the cotrimoxis, or they would not know such names as well. So these are the real issues which I feel that we have to address when we're talking about the impact of climate change on health. It's about strengthening, but we have to define, because all of us were talking about strengthening health systems, really not defining what exactly is strengthening health systems. It involves a lot. So we have to be, give details, and see how best do we address that.
Maybe we could talk a little bit about those details, if we could, for a moment. The government of Malawi has implemented a few plans: the National Adaptation Plan Framework, and an approach called One Health in Malawi. If you could run us through that, what those plans are exactly, share a little bit more about these approaches, what makes them more innovative, and provide an example, maybe, of how they work in action.
Okay. On One Health, basically what we're saying is that in whatever we do in our plans, we cannot ignore animals, we cannot ignore the environment. We are all living in the same environment, in the same space. We have you affect one another in one way or another, and we have seen it. So we are saying we work together, my Ministry of Agriculture, and the Ministry of Natural Resources and the Environment as well, and of course the Ministry of Finance. I'll give you an example. Now there's an issue of antimicrobial resistance. It is real. It is real. In fact, you find that maybe it's killing more people than maybe HIV/AIDS or something. But
killing more people than HIV.
Exactly. So, but it's not being mentioned frequently. It's not being given that kind of attention it deserves. But it's something which it's like we are sitting on a time bomb. It's something which we need to address. So, as Malawi, we have accepted that approach. So now what we are doing is trying to strengthen our laboratories so that they are able, to pick if there are any, resistance to the antibiotics which we use. In Malawi already we are experiencing tuberculosis and resistance in some of our patients. Yes, we have picked that one, and we are already addressing resistance to tuberculosis medication. So that is just an example. So which shows that we really need to be alert, on high alert, everyone, and we have to keep a close eye on the resistance, because if we have that for the other diseases, it will be catastrophic.
very helpful. Thank you for sharing those examples. Convenings like this, WHA, COP, and UNGA in September, very important platforms for governments and organizations to make financial commitments, especially in the West, global South. Did in the time we have about commitments, we spoke about to talk here. Your on the ground insight into these commitments difference.
There have been to say we have received so much support, partners of them, FCD, that's with us. On our own, we cannot make we make it because we have contained the
Malawi is polio free now. You were mentioning.
Yes, we got the message ago. Yes, so we are very, very grateful. At the same time, the need is still there, like I said. For climate change, you are talking about preparedness. I'm talking about I need recovery, because the damages has already been done. I think the thing which we have to keep in mind is that the crisis found a system which is already very fragile. So you're coming from not an ideal place. It was already fragile without even the crisis, because you have adequate infrastructure, you don't have adequate healthcare workers as well. So you already had challenges before even the crisis. So the climate shocks, they're just making it worse. So that is where we're coming from. So we are grateful for the pledges. The only problem I have is that we get so many pledges, but the way they're fulfilled is where I have a problem. It's no commitment at all. We went to COP, there was 1 billion which was, I think, pledged, but when we're coming back, I don't think there's anyone who really has a list of who are the beneficiaries or how are they going to benefit from that pledge. So these are the issues which, I think we need to address. This is time for action, not pledges.
So you would like to see some metrics-based accounting for some of the pledges and how they are fulfilled. And indeed, I just read a report actually earlier today that some of these fulfillment of these pledges 2 years behind plans, depending on which area we're talking about, of course. So the urgency doesn't seem to be there. What if you were to share a call to action that you would like, and on how the global north and developed countries and organizations could help more effectively? What would that call to action be?
My call to action is this is the time for action and not just pledges. Number 2 is the processes of getting the request fulfilled, the funding or whatever. There's so much bureaucracy, there's so much red tapes. When you're asking for help in a crisis situation, you don't have time. I don't have time to put up a 100 pages proposal for a request, and which is going to take somebody months and months to go through it. They don't even give feedback. It's a crisis. Somebody's dying. You have cholera. Everybody knows about cholera. You only have hours. I don't have even a day or weeks. So we are saying the processes, they have to be flexible. They have to be, friendly as well. So it's about the pledging and fulfillment, but it's also about the processes which we have to go through for us, to have any access at all to this kind of funding.
Wonderful. Can you, and in closing, we always like to end on a positive note. You've been here this week, as you mentioned, lots of talks and pledges. What encourages you from the discussions that you've had here at WHA 77 that you might be able to share with us on a positive note of what helps you think like we are making progress?
we are making progress. We should not despair. The challenges are there, but I think together we can overcome them. Look, HIV, 1980s, 90s, it was like a hopeless situation. You know, life expectancy in Malawi, I think it dropped to around maybe 35, 34. Now it's almost 65, almost hitting 70. It is a success story. You know, we're talking about polio, we had polio, but now we have managed to contain it. You know, it is doable. It is a success story. And so we just need to have, you know, smart networking, collaboration as well, and also, you know, trust, transparency, and accountability in everything, from the giver and the one who is receiving. On both sides, there has to be accountability and transparency.
Accountability and trust. I think those are great words to end on. Congratulations again on the polio achievement. That's fantastic. Thank you so much for sharing your insights and your call to action with us. We really appreciate it. Minister Chiponda.
Lois Pace, the U.S. Department of Health and Human Services Assistant Secretary for Global Affairs, for a conversation with moderator Dr. Maisha Alam, Foreign Policy's Vice President of Research, on the interconnected challenges of health, climate, and security.
Hush fell over the room. Yeah.
Hi, good morning, everybody. It's wonderful to be here with all of you in person in Geneva and, of course, to our global audience online. Thank you so much for tuning in. I'm really honored to have the opportunity to sit down with Assistant Secretary Pace this morning for what, as we heard just now, is perhaps one of the most complex but critical challenges of our time in terms of how climate change and health are related. But of course, it extends beyond that. It's not just those two issues. And I'm looking forward to digging into that a little bit with you. The minister from Malawi so eloquently painted a picture of the kinds of realities that her country are already facing. And we know that back home in the United States, there are also these types of crises that are emerging. So to start us off, amidst this growing recognition that health security, economic security, climate security, and of course, national security are interrelated, tell us a little bit about the U.S. Global Health Security Strategy and what it hopes to achieve, and how you expect or hope that it will help prepare the American health system to really meet these compounding challenges.
Yeah, it's a big question. Good morning, Maisha. Good morning, everyone. Happy WHA, and thank you very much, Your Excellency. It's always hard to follow you. But you're absolutely right. We are facing these challenges at home as well. So I think it's important before I get into the global work to acknowledge that. I come from the state of California, which has been dealing with fires on a regular basis. We also, I have family who was displaced in Katrina in New Orleans. And so we had people losing medical records and not remembering what drugs they were taking, right? So we share these experiences, these unfortunate experiences, and we have learned from one another what we need to do to prepare for these tragedies. So we have on the domestic side an Office of Climate Change and Health Equity, which has been set up under our Department of Health and under the leadership of Secretary Becerra. And that is important because, of course, there is a critical intersection between climate change and health. We're talking about fires and floods, or we're talking about lead, right? And yet, importantly, we have to also use this lens of environmental justice, which is why we have a focus on equity. This is not just about adaptation or mitigation. It is about equity at the end of the day and ensuring that climate, our work in climate and health is advancing health equity, is advancing this wellness and reducing disparities for all people, for all communities. How does that look in our global health strategy? Well, you did mention we have our new global health security strategy, which is absolutely bringing in some of the same themes of adaptation, mitigation, and equity. But specifically, and I'm glad that the minister talked about this as well, we recognize that it's not just about pathogens or pandemics, but we're looking at this using a health lens and the intersection of animal, human, and environmental health. So whether that's field epidemiologists in the veterinary space and not just in the public health space, or otherwise looking at digital health and workforce requirements that, again, look at this intersection. These are ways we're trying to pull it all together.
That's a really bold and ambitious vision, and one that, of course, it's going to require rallying across agencies and mobilizing financing and all of that. So what are some of the barriers administration might be anticipating to actually enact this vision, and how do you hope to overcome that?
So are you suggesting that the U.S. is not already a well-oiled machine? And our programs don't already talk to each other? Yeah, so I think the first and foremost, we have to look internally at how we can improve what we do, right? We have this grand ambition, and we have good intentions. I have to start there. You know, everyone I work with understands the urgency of now. And appreciates our interconnectedness. But of course, how do budgets work? How do programs like PEPFAR, you know, talk to even programs like President's Malaria Initiative, let alone find other ways to sync up across all of these sectors? So that's part one, is really just getting in the same room, working through these plans together on the front end to understand what our respective needs are, and importantly, what the resources will be that we are leveraging or using across one another. I think we saw this come together well in the development of our our President's Emergency Plan for Adaptation and Resilience. And that was, I mean, these were huge meetings, right? But importantly, they pulled together all the parts of USG, whether it's, you know, the Department of Health, the Department of Agriculture, obviously EPA, and others, along with state and our foreign policy friends, to say, okay, what are the problems we're trying to solve, and what are the opportunities we have to solve them? Secondly, or externally, we then have to message this, right, and ensure that our partners understand these connections and the ways that we are trying to approach them. Frankly, much of this is bottom up, if we're being honest. Our partners, our ministerial leaders, right, are saying, this is actually what I need, just so you know, and I need you to make adjustments accordingly. So you have the U.S. having launched or been behind, the launch of the pandemic fund, for example. We sit on the board, we work with various partners there, both from the donor community and from countries implementing these programs. Even in that space, we've said, okay, what can we do to fund One Health initiatives? And many of those preliminary projects are focused on these intersections that I'm mentioning. So that's how we're shifting the work.
Yeah, and your last point is actually a perfect segue to what was going to be my next question, which is, as we've already acknowledged, these types of challenges, whether emergencies or slow onset challenges, they transcend national borders. So tell us briefly, how are you working with other ministries of health, with multilateral organizations, and with partners from other sectors to really take forward that One Health approach?
It's important that we're here at WHA this week and having this conversation. We obviously have the resolution on climate change, which is looking at national action plans, which is looking at a roadmap. Congratulations to WHO for getting across the finish line their new global strategy as well, which is actually, you know, focused on climate as one of several pillars, which is notable. So that gives us all the roadmap and the mandate to move forward in that regard, building on the work we were already doing with organizations like WHO, such as through their Attach platform, really looking at best practices and how we exchange information between Malawi and the US, for example, let alone across other regions. I think beyond beyond that, we are, working with usual suspects like Global Fund, like Gavi. These major initiatives were mentioned earlier because they too recognize the threat of climate change. And I mentioned malaria already. These mosquitoes are winning, unfortunately. And so as part of this longstanding investment the U.S. has made in those programs, we have to adapt as well, adapt our thinking, adapt our doing.
Yeah, I appreciate your reference to the climate change resolution and also specifically malaria. And of course, it's just one of many climate-sensitive diseases that are, already incredibly challenging to deal with. And then now the risk factors are only being exacerbated. We're almost out of time, but I would be remiss not to, of course, bring up the pandemic accord. And
it's like, aren't we out of time?
And you are at the helm of the U.S.'s efforts to move that forward. And as we know, there have been some challenges. And so let me ask you this. What, in your view, are the stickiest, to use Andrew's term from earlier, but what are the really remaining challenges that you see to an adoption of that accord? And what does the United States hope to see included to ultimately strengthen pandemic preparedness and international cooperation?
Okay. Well, thank you for the question. I think one of the sticky issues, honestly, has been around what we do and say about One Health. And I just want to say how much I appreciate everyone who's been around this table for so long, really, up until 3 and 4 a.m. in recent weeks trying to figure this out. There's a recognition that we have to cover the waterfront from preparedness to response. And while we absolutely need to also address another sticking point, which is access to innovations, right, and any products that come out of or spur from an emergency, we also just want to do what we can to prevent the emergency in the first place, which is where One Health comes into play. So we are still working through things, as everyone here knows, and I'm an optimist, as folks here probably know about me, so I remain hopeful that we can get this done. I have to say, though, in addition to the pandemic accord, we still have the international health regulations, right, which also are looking at how we prepare for and respond to emergencies that stem from a number of hazards, including those exacerbated by climate. And that feels much closer, and it's, ideally, we have this package of agreements that comes out of this week. But if nothing else, we need something to deliver on for all of the work that our teams have done, but frankly, for all of the lives that have been lost or could be saved by getting this done too. I don't think anyone wants to, nor could we go home empty-handed after this week, because people are counting on us, right? And they've been counting on us for a long time, and we've told them that we can come through for them and that we will come through for them. So that's my goal this week. This is why I'm staying until 11:59 on Saturday to really see this through. And like I said, I remain hopeful that we can actually achieve this together.
I really appreciate, yes, I think that deserves an applause, and thank you. I really appreciate the combination of both candor and optimism with which you answered that question. So I'm going to use my chair's prerogative to ask one last. And it's this, which is, what do you feel is a global health challenge or problem that isn't getting the attention it deserves? And what's a good news story that you wish more people knew about, or a positive trend that you wish more people knew about?
Okay. Well, goodness, this is hard. I am going to go back to my roots and maybe surprise some folks, maybe not others. I worked in cancer for a very long time, and this is something that's important to the president as well. And speaking of bottom up, right, there are people in various countries who have been saying, we care about infectious diseases, but people are dying of cancer, heart disease, and other conditions, non-communicable diseases, if you will. And so I would hope that in our ongoing conversations, we continue to talk about health systems and services, whether we're talking about them in the context of climate crisis or other crises, that we recognize the spectrum of needs people really have and be truly patient-centered to understand that people are whole people and face a lot of different risks and needs. In terms of the good news story, that might also be surprising because I have a lot of faith in multilateralism. And, despite a lot of the hard stuff that we work through here, and there are a lot of hard things, the pandemic accord, gender, a number of issues, we are still here, and we are still finding a way through in a number of ways, right? And it's not easy, but when it works, it's magical. And so what I tend to tell my family when they ask, why are you in Geneva so much? What are you doing? I hear there's nice chocolate and wine and cheese. I say, well, I get to work with people from all over the world to try and solve the problems that you're facing right here, right? Whether it's cancer, whether it's HIV, whether it's, a range of things. And we're doing it, right? I can point to ways that we're actually making a difference. Out of the 15 resolutions, right, if we get all of those through, do you know how many lives will be changed, right? Given this new global health strategy and the billions of lives saved, these are people, right? And this is progress. And so that's my good news for the day. Thank you for asking that question too, because I needed that.
Well, I can't think of a better note to end on. So thank you for being here, and thank you for your leadership. It's great to have you.
Thank you, Maisha.
Thanks.
Now, please welcome Irene Atuhaire, Uganda Country Director for Seed Global Health, Darren Back, Executive Director for the Pfizer Foundation, Dr. Naveen Rao, Senior Vice President for Health at the Rockefeller Foundation, to discuss how partnerships can bolster health systems' resilience to climate and health.
Hello again, and I'm really excited to be able to build on the conversations that we've already had this morning with a really illustrious panel of leaders who are working at the community level, who are working across sectors, who are at the helm of innovation and financing and partnership, to dig a little bit deeper into some of the both challenges as well as opportunities that we've heard about this morning. So Irene, Darren, Naveen, thank you so much for being here. Irene, I'd love to start with you first. And as we heard earlier from the minister from Malawi, she was telling us a little bit about how climate disasters are impacting communities, healthcare, and health systems in and across Malawi. And we heard also from Assistant Secretary Pace a little bit about examples from the US. And so tell us from your perspective and your experience, what are some examples that illustrate how Uganda is grappling with these dual challenges? What are you experiencing in terms of health outcomes?
Thank you. I work with Seed Global Health, and as Seed, we work with ministries. We are seeing it in Uganda. One is with malaria. However, in Uganda, we are seeing a rise in the cases. Up to now, malaria is still the first killer. It's the number one killer in Uganda. We lose about almost 100,000 people in a year. And for the economies out there, we lose about $500 million in a year. This is the impact of malaria. And in 2022 alone, we had about 12 million cases. So you can imagine, malaria also contributes to about 15 to 20% of hospital admissions. So this really puts a heavy toll on the health workers. You find maybe a nurse or midwife has to provide treatment to about 100 patients. When you look at the children's ward, it's full of malaria. So this impacts on the quality of care that she can provide, because most times she's alone and the cases are so many. So she may not be able to provide the quality of care she would like to provide. The other example I want to share is Ebola. So a few years ago, 2021, 2022, we had an Ebola outbreak. And of course, with climate change, we are seeing that these outbreaks are going to happen more and more. Yeah. So during this outbreak, we had about 164 cases with about 30% case fatality. I want to share a personal story of someone I knew, a health worker, an emergency health worker who was responsible for evacuating suspected cases from the community. And he was very diligent, but through his work, he contracted the disease. Mm-hmm. And unfortunately, we recognized it late, and we lost him. So sorry to put a bad mood on, but I wanted to bring the impact of how health workers are losing their lives because of these challenges. So had this health worker been equipped with the right protective equipment, with the right training, the right knowledge, and also, if there were more people, maybe wouldn't have been so tired and forget to wear maybe gloves. He would still be here with us, and he would still be able to provide the care that he was diligent to. Yeah. So these are the impacts that you're seeing in Uganda.
Well, thank you, Irene, and thank you for sharing that personal anecdote and moving story. And we know that that kind of example is far from isolated, unfortunately. And I really appreciate how you brought to the fore the human impact and the cost in lives and in well-being, but also the economic impact that these types of challenges you're already confronting and that are worsening over time. And one of the things that you talked a little bit about was how do we fortify health systems and how do we strengthen existing health systems in order to make them more climate resilient. This is something that we at FP Analytics are passionate about, and for those of you who are here in the audience, you might see little postcards for some research that we did exactly on this topic, on ensuring greater sustainability in healthcare and making them more climate resilient. It's something that for those of you who are tuning in online, you can find on our website. But it serves as a perfect segue to what was going to be my next question, and that was for you, Darren. You have worked on these issues for decades in a number of roles and institutions and contexts. And so, from your experience really trying to lead that effort, how do we actually fortify health systems, especially, as Irene was alluding to, emergency support systems and healthcare networks like Irene's to be more resilient to climate change, to meet the reality we're already facing?
Sure. Well, good morning, everyone, and thank you for describing us as an illustrative panel. That's a nice introduction, too. I think there's a lot of talk, as we've heard, around more upstream impacts and mitigation efforts really around climate change and the impacts of climate change on health. But as we've also heard, communities are dealing with the health impacts today, and they're having a huge impact on communities. And so the importance of community healthcare workers and emergency response systems just becomes even more important. From our perspective, when I think about the work that we do from the Pfizer Foundation, we can't future-proof healthcare systems if they're not today-proof. And so that's where a lot of the work that we focus on really takes place, is going back to basics and really making sure that the fundamentals are in place, the people, the infrastructure, supplies, technology, so that we can fortify healthcare systems today in the right way and they're context-specific, so that they can flex and respond and absorb impacts in the future. And I'd just like to build on a couple of examples, actually, and the great overview that we heard from Minister Chiponda of the work that we're doing in Malawi. Malawi, as you heard, has set forward a very ambitious plan with their National Strategic Plan for Health, which is very much focused on integration of services, which is really going to be key to fortifying health in Malawi. And so one of the programs that we have is working with the Ministry of Health and Seed Global Health. We're actually looking at that integration of services and what does that package look like? Where does it work? Where does it maybe not work so much? And then looking in 2 districts as a pilot, how can we then create a blueprint that's going to help inform the Ministry of Health what will scale and what will be effective in all 26 counties? And then the second example I'd like to bring up, and again, the minister really talked about this, is the impact of AMR. Now, this is inside and outside of Malawi. You know, it's at the forefront for all of us, specifically with climate change, when we think about loss of diversity, when we think about, you know, severe weather impacts that come with climate change. And for Malawi, for example, it's estimated that around 19,000 people die every year due to AMR. And so we're working with the government, and we actually announced last week a partnership both with the government and with bioMérieux, where we're actually looking at AMR at the hospital level. So we're working across the 4 national hospitals, looking at both diagnostics, but also stewardship in antimicrobial use. So it's diagnostic stewardship and antimicrobial stewardship. And then how can we link microbiology to the decisions that are being made in terms of appropriate use of antibiotics? And this is going to have a huge impact not only on health delivery today, but when you think about some of the emergency situations and how Malawi had to respond to cholera, for example, as an example there.
Yeah, that's a great example, and just to unpack it a little bit, I'm listening to you speak, and I like how you kind of talked a little bit about the stages of healthcare. When we talk about making it more resilient, what are we ultimately talking about? And you underscored the importance of detection and diagnosis, but also of treatment and response, and AMR being a challenge that certainly is not unique to Malawi, unfortunately, and spans across the globe, and is one of the most pressing global health and health security challenges that we face. So even where we are making the detection and diagnosis systems and tools more climate resilient, we have to make sure that the response and treatment is equally so. But the other thing that you highlighted, and that Irene, you also touched upon, was of course the role of partnerships. And we know that no one stakeholder or player can do this alone, and that lifting tide will be needed. And so Naveen, I'd love to bring you into the conversation at this stage. And you lead the Rockefeller Foundation's work on global health. The Rockefeller Foundation has been doing this kind of philanthropic investment and support and partnership for more than a century at this point. So what do you see as some of the innovative financing strategies that foundations and governments and civil society partners could explore to effectively fund climate and health in tandem, and not one at the cost of the other?
Good morning and thank you. In the spirit of full disclosure, I'm a physician, and I went to medical school because I was not good with numbers or math. And now I'm reformed because I realize that in order to get global health outcomes, you do need to focus on financing. And at the end of the day, that is the fuel for the fire. And that if you're not good at financing, you're not going to achieve your objectives. So kind of a reformed doctor speaking here. So if I were to look at what is the problem statement, why is there a barrier? Why is climate health adaptation seen as a lesser cousin to mitigation? It's the poorer cousin, lesser cousin. And there are a couple of barriers to that make this gap widening. In fact, they believe it'll be around 400 billion deficit by 2030 in developing countries. Basically, we don't have good information. We still don't even know what is the cost of inaction. We haven't documented that. These structures for financing are complex. They usually, there's not a single measure of value, or how do we even measure adaptation results, and how do we make those exciting and interesting for the partners to come in. So there are a couple of barriers, and so if we start with the basics, Rockefeller worked with Global Fund, Green Climate Fund, WHO, and COP28, and last year at the Health Day, we helped launch the guiding principles for financing. So that's the basic. We need guiding principles, and that was very well accepted, and that liberated about $1 billion in commitments. And then we realized that is the start. We needed to then come to financing and then innovative financing. And so how I want to build the rest of my comments, which are going to be brief, is there's the primary stack. I mean, if you were to stack the financing, at the bottom of that would be primary debt, equity, grants, your traditional financing. And imagine, this is a doctor speaking now. On top of that, we needed to put innovative financing. And there's basically 3 innovative financing instruments out there that have multiple examples. If you go on the net, you will see that these are all being used, some within health, some on other sides, other industries. But we need to be able to learn from them and pick up and drop. The first one is disaster risk instruments. These disaster risk instruments provide quick liquidity and debt relief when there is a climate catastrophe. Now, you heard Minister Chiponda say that there was a day when she's floods and people are dying and she's got this 100-page application form she needs to fill out. Can't we fill out that form ahead of time and have disaster risk instruments that will kick in if there is such a disaster? If we were able to have predicted the intensity of Freddie and what it would have done, then automatically that money is available rather than her having to fill out a form afterwards. So the insurance industry uses this. It's called parametric insurance clauses that say if a predefined event happens, then automatically the money is released. You could also have regional insurance pools that mitigate and get regional monies to come in, and so you spread the risk. You can also have catastrophic bonds that are same way that are come to help during catastrophe. And the last time is also debt relief clauses. Now, World Bank is moving towards this, where it's trying to broaden the scope of debt relief. So when these catastrophe events happen, then there is debt relief temporarily. There's a moratorium on repayments. So the idea is on disaster risk instruments is all about predefining and then those events triggering rather than waiting for the fire to happen and then expect people to ask for money. The second is catalytic instruments. Catalytic instruments is when you put on top of concessional funding, you put commercial funding. But now the commercial funders don't come in too easily because the return on investment, the risk. So when you look at risk and return on investment, we need to make it attractive to the investors to come in. These are the private sector, institutional investors. And to be able to attract them, you need to have these catalytic instruments, which basically say, for example, Rockefeller will use our balance sheet to say we will be the first grantee and that we will be guaranteed that these payments will be paid if for some reason they can't. So we are catalytic, and that over us, then the commercial interests come in, and then we either reduce risk or increase returns. So there's another way to get new money to come in an innovative way. And the last one, which I'm most excited, which is the most recent, is outcomes-based financing. And these are, for example, how can you force financing to go towards outcomes that are tangible and meaningful? And in this instance, I am very focused on global health outcomes. So how can I get money to actually go to projects that will give me good health? Examples here are debt for health swaps. That is, if you get a certain amount of health outcomes, then your debt is released. There is also fiscal credits you can get for health outcomes. So the bottom line is there is financing, and then there's innovative financing, and this is necessary to close the gap. And this is the only way we can get those partners to come in with new money, more money, because we need it on the adaptation side. So that's my story right now.
I so appreciate you taking the time to break down those different types of instruments and their applications. You know, in so many conversations, there's a call to more financing and innovative financing, but there isn't often an opportunity to really get into what does that look like in practice, and how do different approaches address different challenges and opportunities. And one of the things that you were just touching on towards the end of your comment was about how to think about where improvements in health could then also lead to certain incentives for other types of issues. And I wanted to pick up on that and bring in another issue area that the Rockefeller Foundation has prioritized significantly for many years, and especially in the last decade, and that is related to food security. And when we think about food security and food sustainability, that's a health issue, malnutrition, certainly undernutrition, and all of that means for childhood health, for adult health, and the life course of a person. But of course, also its susceptibility to climate change and the very real ways in which climate change is undermining food sustainability. So how at the foundation are you maybe thinking about these two issues as relates to each other?
Absolutely. Thanks for asking. It almost seems like I asked you to ask me this, but
we did. This is not. I promise it's not orchestrated.
It's fascinating you ask this. So we at the foundation, we realized that financing actually can incentivize good behavior. And so, for example, on the agriculture side, we are very focused on regenerative agriculture. How can we actually incentivize farmers to do regenerative agriculture where we are not stripping the biodome, we're not causing downstream problems, but how can we incentivize behavior to get cash crops and to get regenerative, where actually through that agriculture process, you're strengthening the soil and not depleting it. Similarly, how can we get cattle farmers to start moving towards more responsible cattle farming? And so there is a whole way of incentivizing, and this comes to a bit of the outcomes financing I was talking about, that you could actually drive good behavior by incentivizing through financing. And so it is being done, and there are a lot of good examples that give me hope. So in this doom and gloom story that we hear all the time, I see the glass is half full.
That's fantastic, and I appreciate you taking us in that direction. Irene and Darren, I'd love to come back to you now and talk a little bit, building on what Naveen was alluding to, a systems approach, a systems-wide approach to addressing the dual challenges of climate and health, and making both resilient. And so my question is for both of you, and maybe Darren, I'll go to you first, and then Irene, I'll go to you first, and then to Darren. And that's about the role of primary health care. And where does strengthening primary health care fit into making healthcare systems more climate resilient, and also confronting and addressing how climate change is impacting health outcomes?
Thank you. Can you hear me?
Yes.
Thank you. Yeah, so I would say that, of course, as we heard from the Rockefeller, the issue is investment. We need to ensure that we put our money where our mouth is. If we need strong primary healthcare systems, we need to invest in them. And these don't operate in a vacuum. They are done by people, by health workers. So we need to ensure that health workers are invested in, they're trained, they're well-trained, they are recruited. In most of our facilities, we don't have health workers. We have 1 or 2 for a shift. They are, paid, and they're also protected. They're given everything that they need to perform their work very well, and also protect us. Because, you could come into the health facility, if the health worker is not protected, you end up going out with maybe a disease. So I would say that the issue we need to do is to invest in the health systems, but particularly the health workforce, which is, the backbone of health systems. And that also trickles down to primary health care. Thank you.
Great.
And I'll build on that, just to absolutely agree. It really is around the community healthcare workers, but also the community themselves. You heard the minister talk earlier about cholera, and I happened to be in Malawi soon after the cyclone and was visiting a community with a partner. And they were having their immunization program, but they were also dealing with COVID, and now they were dealing with cholera. And all these things are being thrown at these community leaders and community healthcare workers. And so it's really ensuring that the system is able to respond and flex to these changes. And particularly from a Pfizer Foundation perspective and just bringing the financing piece, what we found is really key is, direct investments right now are important because, as I mentioned, communities are dealing with these issues now, but also the flexibility in that funding as well. Because we recognize that when we work with ministers, these things are changing day by day. So it's important that as an investor, we're able to be flexible in that financing as well so that we can also flex and adapt.
That's great. As I'm listening to all three of you speak over the course of this discussion, and you play complementary but distinct roles and sit in very different perches. But I just want to go back to something that Irene, you said at the outset, and I think is worth repeating, which is when we talk about healthcare workers, what we're really talking about is the front line of defense. That's the front line of defense in terms of health challenges, but it's also the front line of defense in terms of climate challenges, right? And at the end of the day, what are we really doing here? We're talking about people's lives, whether that's patients who are having to deal with disease burdens, or whether that's healthcare workers who are trying to deliver healthcare. It's about individuals, about families, about communities. That's ultimately what we're talking about when we talk about these issues. So I really appreciate all of you bringing your perspectives to this discussion, but then keeping us straight in terms of what's it all about. So thank you for being here. Thank you for your leadership, and I hope that you can continue to expand the work that you are all doing and do it well. So.
Anurag Hans from OneSite Elisor Luxottica Foundation, and Sandrine Flavier from the UN High Commissioner for Refugees for a conversation with FP's Executive Vice President Alison Carlson on how improving eye health unlocks opportunities for refugees.
Great. Hello, good morning. Thank you for joining us. And thank you everyone for being here. We've got a packed room and really appreciate the energy. It's been a big week for everyone here. And also thank you for everyone joining online. I know not everyone had the opportunity to join us in Geneva, and it's really important that the lessons learned and the stories shared reach everyone around the world. So I appreciate everyone tuning in today. And we've heard a lot so far about complex global health challenges. And one of the things that I'm excited about this program today is we're addressing not only the complexity of a lot of these health challenges, but also those issues that are overlooked and don't get as discussed or as much research funding, but are right in front of us. And so I'm really excited about the conversation today about vision and addressing poor eyesight around the world, but particularly as it relates to refugees and displaced populations. You may not be aware, but over 2.2 billion people around the world have poor vision. And about half of that could be corrected with relatively low-cost interventions. And we're talking about innovations, and we often think of advanced technologies and what could be done in that regard, and often overlook some of the lowest cost interventions that can have real, immediate, and cascading impacts. And so, Anurag, I'd like to turn to you first. When you're thinking about this challenge in the work that you're doing and the foundation, how do you see this issue in terms of being able to intervene for what is one of the largest disabilities around the world? And what are your priorities in terms of tackling that problem and how that can really address not only eyesight, but the Sustainable Development Goals?
Thanks, Alison. We believe that uncorrected poor vision or having blurred eyesight, to be simplistic, is the largest disability and the most hidden disability in the world. And there are a couple of reasons for that. So to put it simply, 1 in 3 people cannot see the world clearly. Now, that might not be true in this room, but it's true in every developing, underdeveloped context in the world. And if you think about it, it's not really a health problem. It's a quality of life problem. And also, I see it as probably the biggest opportunity to unlock productivity in front of the world. The primary reasons for that are there is no access. People do not have a place to go to get a simple eye check and a pair of glasses. There is no awareness. People don't know that they have a problem, or there are social taboos. And the third problem is that the policymakers, the influencers, the decision makers sort of take this for granted. If I look around this room, probably 1/3 of the room is wearing a pair of eyeglasses, and for us it's very intuitive. If I have a problem with the eyes, I know where to go. I know how to get a pair of glasses. But if for people in the room who are wearing glasses, if you take off your glasses for 5 minutes, you will realize what 1/3 of the world lives on a day-to-day basis. But I'm not trying to paint a very depressing picture, because we look at this as a big opportunity to unlock holistic quality of life. There have been multiple studies on hundreds of billions of dollars every year on lost productivity because people can't see clearly. But it goes beyond. It has a link with seemingly unrelated facets of life. Educational outcomes, gender equality, female labor force participation, even climate change. So there is a strong link, published research on how a simple intervention of helping people see clearly can make a huge difference. It has a linkage to most of the SDGs. And there is evidence to suggest how this intervention could be the medium, and probably the easiest medium through which you can make an impact across these areas. With UNHCR, with refugees and humanitarian relief projects, we decided to try this approach with UNHCR because we really believe that having this intervention could make a substantial impact in the lives of those who have been displaced, who have been forced to leave their homes. And the same model applies with many other aspects which cut across SDGs.
Thank you for that, and I love to bring you in, Sandrine, to paint the picture and to provide some context in the work that you're doing. Over 100 million people around the world are refugees, are in displaced situations, areas of conflict, and we're seeing that around the world. And also 3 out of 4 of those with poor eyesight are in low and middle income countries that don't have as direct access to healthcare. And so in the work that you're doing, and we'll dig into this partnership a little bit more in just a few minutes, but in your experience and the work that you're doing, how are you seeing poor eyesight affect the populations that you're working with?
Thank you, Alison. I think, is it working? Yes. No? Yes, now it works. So I think, as you said, 2023, 114 million refugees in the world, so the highest number ever. And, when we're looking at perspective, the number is going to increase. And of course, when you're looking at the needs, and when you're looking at the resources that we have, definitely there is a huge gap. And so in organization, we have to prioritize and we have to deprioritize. So when we're looking within the health interventions, obviously we have to focus on the life-saving interventions and, also on things like vaccination or baby deliveries. And unfortunately, there's a lack of research and data and a lack of ability to be able to, give the support needed when it comes to vision. However, and that's where it's a sad story, I would say, when you're looking at vision care and how, disabilities in the vision space is impacting population, refugees are particularly vulnerable. First, as you know, they have to flee their home. They are in context where usually there's violence or conflict or climate catastrophes, and then the health system are not fully in place. They have to leave everything behind. They are highly distressed. When they move to new location, they are very often in rural areas or in camps, which are far from the health facilities. And so the access is particularly difficult. But also, if you had the extra burden of already they are in a very, distressed mental space, but you add the extra burden of, the vision disability, it's adding a lot of stress, and also is impacting heavily the capacity to adapt, to communicate, to be able to embed themselves in a new culture and environments. Nearly half of the refugees, of the number I mentioned, are children and women, as you said. So, they go through education, for example. This is a bit of the lifeline for them, in those contexts. If you have issues with the vision, the impact is really, really big. And when I'm talking about women or men who have to look for a job, who have to, care and provide for their family, having vision disability is impacting them as well. So the really it's driving them even more into poverty and mental distress. So that's why, we cannot fix on our own, I would say, these issues, and we're really calling for a collective action. And that's why partnership, and I know we talked about partnership also in the session before, is absolutely essential if we want to fix the problem. The needs, just to say, are around research and data. It's around innovation, and I'm sure you will talk a bit about this. So looking at innovation, it's of course the funding, but it's also, helping us to raise awareness to the different local actors about the importance of this issue, and it's also about, training locally. And this, we can do it with the private sector.
Right, and you're talking about around 3/4 of refugees are in low and middle income countries where those who are finding themselves in host countries may not have access to healthcare, issues related to rural access, et cetera. And so I'm wondering very concretely, how are, to your point, partnerships, how are the one between UNHCR and OneSite really addressing those issues in concrete ways in those kinds of complex environments to deliver the access that those may not be able to gain otherwise? Go to you first, Anurag, and then Sandrine.
So there are two layers of impact that we are talking about when we are looking at a partnership like the one that we have with UNHCR. The first one is straight up a health issue which needs to be solved, which unlocks productivity, or the ability for these refugees to seamlessly integrate into the new context that they find themselves in. So on that one, obviously, working with UNHCR makes it easier for us to access these communities, and then we make it a point to make sure that these don't come across as one-off interventions. So we make sure that permanent capacity is built to take care of these communities even after the teams have left the location. The second order of impact is the fact that most of these refugees are hosted in low and middle income countries is also the biggest opportunities for us to create economic opportunities for them in the field of vision care, because that is the same geography where these 2-odd billion people who are looking for eye care are present. So the second order of action and impact is going to be us training these refugees to become vision care providers to those people in those communities. So we really think that this can have sustained impact, and we can turn this crisis into an opportunity, both for the communities that are hosting them and for the refugees who will reap the benefits.
Thank you for that. And Sandrine, can you give us some examples of some projects that you've been working on together on the ground? I know you've been in Moldova and elsewhere. How are you seeing this manifest and the kind of impacts that Anurag is talking about?
Yes, so
Just an intro line to say first that the partnership indeed with the One Sign Foundation is a good practice. And I will say just why very quickly. Very often we have a lot of companies coming our way who wants to give us a large number of glasses. This is a one-time intervention. And this is all well intended, but what we're looking at is really a partnership where, you know, we have a partner like you that really want to be an actor of change, engage on the long term and at scale. So when we had a Global Refugee Forum in December, you know, the One Sign Foundation made a pledge. And it means that there is a commitment over 4 years to support more than 100K refugees. And this is what we're looking at, this full service, so we work on this together. And we act through our projects on two key things. There is first, you know, making sure that we bring the vision care service, equipments and so on to the people we want to serve. But there is also the second part that is, I would say, even more the most interesting one, which is to make sure that we build a local capacity so that the interventions and the projects are sustainable. So if we leave tomorrow, which is the hope, I would say, then, you know, the system is built. And indeed, we've been working in Italy, in Greece, in Moldova. If I just focus for 1 second on Moldova, you know, the One Sign Foundation, we are establishing mobile clinics that are supposed to be temporary, but in those clinics, there is, you know, the equipment that is given by the foundation, but you also have the training of local volunteers or staff who can actually, you know, learn and then give the vision support. You have the equipment, you have also the ability to bring around the table the different local stakeholders. So I'm talking university, volunteers, the local authorities, and that's the strength of the partnership. So we raise awareness, we educate key stakeholders, and then of course, ultimately, we give the service and we support, you know, refugees and the host communities, which is the strength. So it's not just the refugee, but it's also the communities in which they are embedded.
You raised so many important points about those kinds of interventions, not only the financing for them and the resources, often in places that are incredibly fiscally constrained, and needing to ensure that those investments of time, resources, training are sustainable. And how to do that so, as you said, so you can leave, and so the community can continue on in your absence. And so when you think about that, and the example in Moldova, Greece, Italy, elsewhere, how are you then replicating that? And how are you able to take those lessons learned and apply them to very specific contexts? Understanding you need scale, right? But they need to be context specific and relevant to the population that you're working with. And so, Anurag, how do you think about that? And then Sandrine as well.
So it's exactly what you said. It's context specific. So even though we have a very successful partnership with UNHCR in Moldova, primarily for the Ukrainian refugees, in Greece, in Italy, but it's context specific. We'll take our learnings from these locations, but let's say if we do a similar program in another community where the refugee population is probably a bit more entrenched. And it all depends on what is the time horizon for which we are trying to build an intervention. And which brings me back to the point that I was trying to make, that if there is a need to create new livelihood opportunities for the refugees to become a part of those communities that are hosting them, by becoming primary vision care providers and earning a livelihood by providing vision care services to those communities, those are the steps that we will take. And that's like the second order of how this partnership becomes sustainable, becomes more permanent. And we don't need to, after 2 years, go back to the same community to do an intervention because we've solved that problem for good in the first go.
Mm-hmm. And how are you designing and crafting these programs also, again, so they're context-specific, locally relevant, but enable you to leave?
So I think, without playing with the words, but I think it's first having the same vision. So having the same vision for the partnership and knowing that we have several years ahead, we can actually really co-create together. So it's not just a one-time thing. So we have system in place, you know, with regular meetings, regular learning, bringing in, some champion within UNHCR, and it's the same within your organization, so they can exchange, learn, and every time readapt based on the good practice. I think there is also some more work that we will be doing coming up on this research, data, and measurement piece, because I think this is really something that we need to track, and that will be very useful to also share about the partnership and the success internally within our organization, and then ultimately bring new partner on board, because that's also the one of the objectives, to make sure that we inspire others to join and support.
Sure. And not only the research, but then being able to utilize that data for the direct and indirect and cascading impacts throughout the economy, as you were describing earlier. So we have just a few moments left, and as you were noting, these are complex issues, but one of the things I've appreciated in our conversations thus far and in the days prior has been both of your optimism and constructive approach to these issues. And in thinking about the opportunity here and thinking constructively, positively, what can be done, and your calls to action here in this space, and to those who are tuning in who may not be as familiar of the issue, or even thinking about some of the innovative partnerships that could be forged, what would be your call to action and your takeaway that you'd want this audience to hear? Sundrine, to you, and then Anurag, to you.
So maybe I will use one of the sentences you say at the beginning when you say, it might not even be a health issue, meaning that we know how it can be fixed. So I would say, what's important for me is it's the modalities of the partnership that we have. And I will be calling, if there's anybody in the room, I would say, who wants to be an actor of change and engage over a number of years to have a really sustainable impact, well, to come forward and talk to us.
And from my side, again, as I said, this is, for us, the One Sight EssilorLuxottica Foundation is the largest foundation in vision care. But that doesn't mean that we look at vision care as the end goal. We truly look at this as an enabler, a cross-cutting enabler. So our partnerships with UNHCR to improve the lives of refugees through the medium of vision care, or our partnership with the UN Road Safety Fund to improve road safety through the medium of vision care. Or, we worked with some foundations who focused on financial inclusion through the medium of vision care, creating livelihoods that provide vision care to their communities. So the only takeaway to people in this room and beyond is, if you're focused on education, if you're focused on gender, if you're focused on livelihoods, think about vision as probably an easy medium through which you can make sustained impact. Because if you think that there is no correlation between the impact area that you're interested in and vision, maybe think again.
Very well put. Thank you for bringing it to our attention and sharing your experience and your projects with us, which are replicable, scalable, and also inviting everyone in this room and those who are tuning in to connect with you, to think through how can we all be bolder, and really collaborate more effectively to have the impact that we're all seeking to achieve. So thank you. Appreciate it.
Thank you.
Thank you, Sandra.
Stage, Kana Enomoto, McKinsey Health Institute's Brain Health Director, for a conversation on women's mental health.
Hello again. As I was mentioning earlier at the outset of our previous conversation, we really have an opportunity here to tackle a number of issues that are underappreciated and not as commonly addressed. And so we're kicking off this conversation today talking about mental health, and specifically as it relates to women. I think probably everyone in this room knows someone who is struggling with mental health, whether it's in their family, their communities, in the workplace. And it is an issue that is under-discussed, under-researched, and highly, highly stigmatized. And we need to be talking about it more, researching it more, and understanding it more completely to really understand what are the interventions that can be had and engagement and access to healthcare that it will really have impact. And so appreciate you all being here for part of this conversation. And it's a really important one. The World Economic Forum has found that 1 in 4 people are affected by mental health, and women are about twice as common to be diagnosed with a mental health disorder. And this ranges from anxiety, depression, can result in suicide, substance abuse, and those impacts are cascading. And so, Kana, I know you've been dedicating your work to these issues and understanding them more deeply from a research perspective. And so, in your work, can you help characterize the complexity of this issue and also how it's manifesting with women in particular and some of the drivers for mental health?
First of all, thank you for having me here, and thank you for focusing on women's mental health, because as you noted, it is, mental health in general is sort of underrepresented and lacks investment and action in the way that we need it, and I think it's exciting that it's coming onto the agenda here at World Health Assembly. And then women's mental health in particular, right, is really not well understood, and we don't talk about it enough, and yet it affects so many of us. Women's mental health, women's brain health, that occurs in a context of overall women's health disparities. And so we know that women, despite enjoying gains in life expectancy and living longer than men, they actually have a disproportionately shorter, so longer lifespan, but they have a disproportionately shorter health span. So that women live 12 years in poor health versus men who live about 9 years in poor health. And so that compounds the issues that we are seeing in brain health, where you talked about 2 times as many women experience depression or anxiety, even PTSD, which we often have associated historically with combat in men. But because of issues like trauma, because of issues like sexual assault, we have domestic violence. Women are more likely actually than men to experience post-traumatic stress disorder. And then we have a complex array of challenges. So 1, we're not aware of the issues. 2, we don't really understand. We understand many things. I don't want to disparage the volume of research and data that we have to highlight these disparities. But still, it's an underinvested area of research. We don't have enough data. We see that many cases, about 50% of cases of depression, of headache, they occur in conjunction with hormonal transitions. And yet we have very little data on onset of menstruation, onset of menopause. Some of our McKinsey Health Institute data show that 2 out of 10 women have a lifetime diagnosis of menopause, even though we know that 90% of women experience symptoms of menopause. So that is one of the areas of health where we're missing it the most. And so if we're missing menopause, then we're missing the mental health-related sequelae of menopause. And so we have looked at the women's health gap, right? Like I talked about the gap in the overall health disparities. There's about $1 trillion health opportunity. So if we could close the gap in knowledge, in access, in treatment and care for women, across the health conditions, we would gain $1 trillion in productivity and reduced healthcare spending. About 1/4 of that is driven by brain health conditions. So that is $250 billion that we could recoup by 2040 if we invested in women's mental health.
Yeah, it's so important. And when you talk about those costs, clearly there are the cost to overall well-being and the cost to families and lived experience, and the cost to economies, how those impacts are translating in one's ability to go to work, one's ability to care for one's family, and how that ultimately scales, and the impact of those more upstream interventions. If those issues were to be addressed, and if women and people more broadly had greater access, the benefits and the economic benefits that could be associated with that. I think the statistics too of the cost of not addressing these issues is around $6 trillion annually by 2030. And that's more than, cancer, respiratory disease combined. And so when we think about those and the impact of intervening early, I think it underscores your point and the ways in which we really need to focus on access. And so when you think about access in the work that you're doing, what are some of the interventions that are working? Because in research that we've done as well, we have produced, and I think there's some cards on the table in partnership with Beatrice about a paradigm shift in Latin America. And what we found is that across Latin America, there's interventions in psychiatric hospitals, for example, and that's where very limited funding is being addressed. But it's been found that those interventions aren't working. And so in the research that you're doing and with McKinsey Health Institute, what are you finding are those interventions that are in fact having the impact, and what little resources are being allocated to this issue can drive change?
Yeah, those are great data, and it is really important to understand that, globally, countries are spending about 2% of their health budgets on mental health, even though it is driving 1 out of 10 disability-adjusted life years, or costing us $6 trillion by 2030. We see that 2%, the bulk of that is being spent in facilities, right? So we're really kind of housing, caring for the very sickest people, and we're not investing in the primary care, in the prevention, in the community care that we know people need to both stay well and get well. So, we have been talking about could we take a page out of the UNAIDS playbook and say, 90-90-90, what that did for HIV. And essentially it is a public health approach to almost any condition that you would take. That 90% of people would know their status of whether or not they have a mental health or a brain health condition. 90% of people who have one of these conditions would have access to evidence-based care. That's not psychiatric, that's not long-term psychiatric hospitalization, right? That is care in the community, that's preventive interventions, that's family-based treatment, that is peers and social supports, and that is being driven by and with people with lived experience, right? And then that 90% of people who have access to care then can manage their symptoms and move toward recovery. And really, recovery should be the expectation, but we're far from that, and I understand that. But I think that's the bar that we should hold for ourselves. That's the vision that we should have, that only 50% of women with postpartum depression ever get detected by a physician, right? And we know how dangerous postpartum depression is, that it can have complications of suicide, of psychosis, and that has a dyadic impact, right? It has an impact on the developing child. So why isn't it a universal screening for postpartum depression for every woman on this planet, or every person on this planet who has a child, right? This is a real issue. We screen for other things. We take blood pressure. We screen for HIV. We screen for other infectious diseases, for other chronic diseases, and we're not asking the thing that affects 1 in 2 people in their lifetime. And my friend Tom Insel says there's 2 kinds of families. There's the families who have been affected by mental illness, and they're the families who will be affected by mental illness.
It's poignantly put, and when you're talking about 90-90-90, I think that's a great example, models that have worked, or examples you can point to. And so what needs to happen as it relates to mental health to get to that vision? What needs to happen this week, now, going forward, to bridge that gap, to be able to align mental health issues with those goals?
Right now, and this week, and in the coming months, there are important conversations about financing in mental health. We're working across partners, across sectors, talking about how do we increase the commitment and the investment that not only governments, but also private donors, private capital are making in mental health, in brain health, and in women's health. right? So our colleagues at United for Global Mental Health estimate that there is a $200 billion funding gap between what is needed and what is being spent on mental health. If we could close that funding gap within our lifetimes, imagine the potential that we unlock for women everywhere, for families everywhere, for businesses, and for society.
And so what would your call to action be to those in the room?
My call to action is, what can each of you do today, either to raise awareness, right, to increase understanding, and to galvanize others into incorporating mental health in what you do, what you're thinking about, how you're prioritizing the work that you do. You could be in ophthalmological health, you could be in venture capital, you could be in government, but mental health really is in all policies. Gender, sex, they are in all policies. And I hope that in whatever you're doing today, whatever you're doing tomorrow, you're thinking about, does this have a mental health implication? Does this have a gender implication?
And what actions can be taken to acknowledge it, prioritize it, understand it more deeply so that you can have the impact, we all can have the impact in the work that we're trying to do. So thank you for your research and your work on this and your partnership as well.
Please welcome the Honorable Ahmed Abudali, the Governor of Wajir County, for a conversation with FP's Andrew Solinger on universal health care in Kenya.
So nice of you to join us. As I think some of you may know, the Cabinet Secretary for Health of Kenya, Minister Wafula, was called away back to Nairobi, but we are so fortunate to have Governor Abdullahi here with us. Thank you so much for joining us. We really appreciate it. We wanted to talk with you a bit about Kenya's UHC initiative, Universal Health Care. And interestingly, when we speak with the Cabinet Secretary, we'd be talking about the kind of top-down approach, but you provide a really interesting perspective on this as a governor of a district, a rural state, where you'll need to really implement a lot of these policies and can give some perspective on it. So I'd love to kind of understand a little bit more about that, Kenya's journey towards UHC, the recent legislative changes that took place, challenges, and what's and how that's been able to provide affordable and accessible health care. So maybe you could just walk us through a little bit about the legislative changes that took place, overhauling Kenya's health system and infrastructure.
Thank you very much. My name is Ahmed Abdullahi. I am a governor of one of the counties, and I double up as the vice chair of the Association of the Governors. It's called the Council of Governors of Kenya. So healthcare is largely devolved in Kenya, which means the implementation of the norms and standards set by the national government falls squarely on the counties. Actually, the national government runs about 6 facilities. So the rest of the facilities, level 2 all the way to 5, which are something in the region of 17,000 facilities, actually run by the county governments. The UHC, universal health coverage, is largely from the fact that healthcare is a right under the Kenyan Constitution, the Constitution which we promulgated for ourselves in 2010, requires that government actually provides healthcare to everyone. And it tries to tackle 3 things: access, it tries to tackle quality and cost, basically. And it's been a journey. It's something that started some years back. On the legislation, we now have the Public Health Care Act in place. We have a, we call it the Primary Health Care Act, We have a Social Health Insurance Act. We have a Digital Health Act, and we have Facility Improvement Fund Act. So these are the four pieces of legislation that were passed recently to try and anchor UHC and aspects of it into law.
Okay, great. Thank you for explaining. The new UHC legislation required enhanced contributions from citizens as well as employers, and you got a bit of pushback over that. I was wondering if you could talk a little bit about your experience implementing those changes and what were successful strategies for creating public and private buy-in to ensure that the system is financially sustainable.
Yeah, like all good things, when you try to implement something new, there will, of necessity be some resistance to change. I think it's human nature because there are a lot of players in the healthcare space, and trying to get onto these new platforms, be they underwriters, of healthcare insurance, there'll be some level of resistance. But in terms of strategy, I think what has worked for us more than anything else is mainstreaming the community health promoters. Under the old system, we had something called CHVs. They were more, voluntary in nature. We used to call them community health volunteers. But now they've been renamed to promoters, and they get some stipend, which is shared on a 50-50 co-pay arrangement between the national and the county governments. We have thus far recruited, quote unquote, 107,000 community health promoters.
Wow. What is a community health promoter? Maybe you could describe how they integrate into the broader health system.
These are people who take care of 100 households in a community, and we usually say the work is threefold, is to prevent, protect, and promote. So what they do is basically explain healthcare and how the system works and the referral system to the communities. But they also are kitted with basics. They're able to check someone's temperature, their blood pressure, their sugar level, and then also carry basics, for instance, malarial tablets in the malaria-prone areas, and some paracetamol in case someone has a high fever. But they also then explain to this person that their situation is complicated and they probably need to get to a health facility. So they are there in the community identifying who is unwell, who needs help. They also explain antenatal care to expectant ladies and link them to facilities. So, and the whole idea is to move more from the curative to preventive and promotive strategy. As a way of bringing down the cost of healthcare.
And while this sounds very grassroots, there's actually a technology provider that helps implement this, Safaricom.
Yes, they are provided with a smartphone equipped with what is called an electronic community health information system, which provides them with a lot of information, but which also helps them take all the details that they need to then transfer to someone at a facility.
Excellent. Just a minute left. I wanted to kind of dig into some recent crises that have occurred in Kenya, record floods in the that really swept across the region, East Africa into the Mideast as well. How does emergency relief and UHC coexist and work together? I'd be interested to know what steps either the community health promoters or other organizations play in these scenarios where you have emergencies that need to be addressed and climate crises.
Yeah, we've had two, initially we had 5 cycles of depressed rains, And then the last two seasons were, the El Nino of November, December, and then the weatherman called the southern Kenya floods, which were, the recent rains, and they caused a lot of suffering and disruption, really, to transportation and displacement of communities. And the CHPs are critical because these are people who are actually able to literally foot in those terrains, carrying the kids on their back and helping people in their communities in the situation in which they're in. And they worked very well with the disaster response teams, with the also with the Kenya Red Cross, and in some places, of course, the military and disciplined forces also had to come in to try and respond to the emergencies. So that they are able to give basic fast response, even in situations where there is either extreme drought and communities, especially among the nomadic pastoralists that are up in the north, or in flood situations like we had recently, because they are part and parcel of the community, was a good thing. Yes, there are challenges, but I think Kenya is on course to give universal health coverage to its citizens. There'll be challenges, there'll be funding challenges, there'll be coordination challenges, there'll be some resistance to change. But we feel on the ground as governors that, yes, something is changing and we're all better for it.
Thank you so much. Governor Abdullahi, it was actually really refreshing to get a local perspective on some of these implementations, how community health promoters are really helping to lever UHC. Thank you so much for joining us today. I appreciate it.
Thank you very much.
Thank you.
Next up, a discussion on healthy cities with Lars Hartenstein, McKinsey Health Institute co-leader, Dr. Lutz Hegemann, President of Global Health at Novartis, Dr. Ashwin Vasan, New York City's Health Commissioner, and FP moderator Dr. Maisha Alam.
Hi, everybody. It's great to see you all again, and I'm really excited to have Lars, Lutz, and Ashwin with us for this important conversation that takes the discussion on strengthening health care and health outcomes to an even more local level. Just now we were hearing from the governor from Kenya talking about at his county level the ways in which they're both adapting to the realities of a changing world and trying to ensure universal health coverage. And now we're going to actually be going to the city level and talk a little bit about what that looks like in urban areas. And we know that urban areas are at the forefront of some of the most pressing health challenges of our time, from managing impacts of climate change to reducing health disparities to helping people get a good and healthy start in life. And to set the scene for this conversation, I'd actually love to start with you, Lars. The McKinsey Institute has some recent research that emphasizes the potential for city-level interventions to improve health outcomes and to do so significantly. So could you provide us briefly an overview of your findings and what your research suggests in terms of the primary factors to strengthening healthcare at the level of cities?
Very happy to. So first of all, just one word why we are actually looking at health in cities. So from a McKinsey Health Institute perspective, we are interested in catalyzing action on underinvested areas of health, such as mental health, healthy workforces, women's health, and others, healthy longevity. And what we found is that cities are really a place where one can come together to have impact and make progress on these areas. So why cities? By 2050, 70% of the world population will be living in cities. In high-income countries, that's 90%. So the first reason is we need to focus on cities because cities is where people live. There were previous discussions on disparities. The second reason is cities are where, within very close proximity, the health disparities are largest. So there are cities in the US where there are between neighborhoods 30 years of difference in terms of life expectancy. In London, there's a study that on some tube lines, with every stop, the life expectancy goes down by 1 year. So disparities are huge, but disparities are also indicative of opportunity. We did an analysis of urban areas across the world, and of course, there's a correlation between life expectancy and income levels, but at the same time, regardless of income levels, it's possible to have a life expectancy of 77 years. Regardless of income levels, there are urban areas where there's a life expectancy of 77 years. So that's the second reason, these disparities within the cities. The third is really in the cities is where if you have a preventative perspective on health, is where our life and our health plays out before we access the health system eventually. It's where we live, where we socialize, where we engage or not in physical activity, where we are exposed to air and heat and other stressors. So cities influence our health globally. I like to say they're a composite driver of health, perhaps the largest composite driver of health that we can have. And then lastly, it's a place where stakeholders can come together. Private sector and the public sector and also the social sector. And the leaders also, as well as institutions, are often invested in these places. If you live as a leader in a city, your children, your parents may be there as well. So you can invest and have an incentive also personally to invest in the place with a longer time horizon, which is what is needed, especially with the preventative angle. I don't want to go on too long. And I also don't want to ask questions to the audience in a panel discussion like that, but I'm just going to say 3 quick things. And you can think of the answer, and I'm going to give it the right answer right after. So what percentage of countries have a top-level official who is focused on health? The answer is almost 100%. Health ministers, they're all here right now. Some very small island states and so forth have composite departments, but like near 100%. What share of the large cities in the world have a top official focused on health? It's about 1/3. It's about 1/3 focused on health. What share of delegations here at the World Health Assembly have a member representing a city as part of the delegation? I can't tell you for sure, but I think the answer is 0%. So just give you a little bit the law of the land. So I think we're moving in a great direction with the city events that we have this week.
Well, we're certainly lucky here in that we have one such leader with us and on this panel. And so your comments, Lars, serve as a perfect segue to bringing Ashwin into the conversation. And you, of course, are the health commissioner for New York City. You have highlighted the critical need for coordinated policy for health across the United States. And we were fortunate to have an excellent article from you laying out your vision and really making the case for why this is so important, published very recently in Foreign Policy. And for those of you who are able, I would strongly encourage you to take a look at that and have a read. But I'd love to really understand from you and ask you, speaking on your experiences in New York and a city as large, as vibrant, as diverse as New York, can you elaborate on the kinds of public health policies that can be leveraged at the city level to improve health outcomes? What does that look like in practice, and what is it that you're trying to do?
So it's great to be here. I hope this is on. And it's great to be in a number of events on cities as the only city health official. Most of you probably live in cities, And here we are at the World Health Assembly with nation states talking about cities. And my hope is that this is the beginning of a virtuous cycle where more and more city leaders are actually present here, bringing their perspective for the very reasons that Lars mentioned from a demographic perspective. But from a health perspective, it's clear that cities are very much the canaries in the public health coal mine, whether it's pandemic preparedness, infectious diseases, chronic illness, and the convergence of commercial, social, and economic determinants of health, whether mental health, the impacts at a local level of climate change. It's all playing out in our cities. And we ignore the ground level experience of places like New York City and many, many others across the world at our own peril. And what's absent here at the World Health Assembly, at UNGA, at these sort of decision-making tables, even nationally in my country and many countries, is a governance structure that allows for cities to have a voice. And we saw this during COVID, where we didn't know, or we weren't sure that the real world experience from New York City as the epicenter of the pandemic was actually being heard, and where were we able to influence what was happening across the country, but also could we learn from other jurisdictions that were facing different challenges. So I hope that this is the beginning of a process. What Lars mentioned is very important because cities are not organized in the same way. We in New York City have a strong executive, strong agency, strong health executives and other executives. That isn't the case in every city. But what is clear that every city, particularly with the demographic shifts and health shifts that Lars mentioned, and that the McKinsey report highlights, is that every city needs a health strategy. And too often in cities, we are on the back foot just reacting to data as it comes, rather than planning in the long term. And so in New York City, we, coming out of the worst of COVID, where the health strategy was one thing, fighting COVID, we said, what's our long-term plan? And we experienced the steepest drop in life expectancy in New York City in 2020 of any place in the world. Some of that's not surprising as the global epicenter from COVID, but we're not on a path to getting that back without intentional design and without intentional planning. And so we launched Healthy NYC to tackle the leading causes of premature death below 65, excess death in vulnerable communities, and leading risk factors across our city in order to get us to our highest ever life expectancy, 83 years by 2030, and to do so not with the health department or me as the single entity leading that, but rather bringing a cross-sector, cross-agency, and a public, private, nonprofit, and philanthropic approach, all of the pillars of our civic infrastructure, led very much by our executive. Our mayor is fully behind this, and it's his initiative, it's the executive initiative. The last thing I'll say is that we understand that this is long-term work, and so after launching the initiative in November, we also passed a local law to encode it into civic planning. And so every 5 years, we have to come back to the table, reassess our goals, our progress against those goals, and rinse and repeat, regardless of who's in my seat or who's in elected office. That is now a part of our public policy discipline in New York City, and it won't go anywhere. And so we need more of that. We hope that that's the beginning of both a national plan. I think it's the beginnings of what I like to call an industrial policy for health, but I think we need to see this in cities all across our country and the world, for sure.
Yeah, thank you for all of that. And I will say so much of what you were describing about New York City and being the global epicenter of COVID-19 resonates with me personally. I was living in Manhattan during that time within walking distance of 4 major hospitals. And so, so many of us, I think, can relate to that. And the other point that you made that I think is so critical to underscore is learning from the pandemic and creating a bolder vision for the future one that leverages a whole of systems approach and brings in partners from across sectors. And that really serves as a perfect transition to my next question. And I'd love to bring you into this conversation, Lutz, and in your leadership at Novartis, this is exactly what you are focused on. And so, Novartis has been working through public-private partnerships to address the upstream social determinants of health, and in particular of cardiovascular health in vulnerable neighborhoods. What does that look like in terms of that effort? And how do these partnerships leverage the expertise in data science that you all have to help devise interventions that are most effective?
Yeah, thank you very much. Thanks for having me. Let me start maybe by reflecting a little bit the journey that Novartis have been on for the last 30 years with the aim of driving greater health equity. We probably called it differently 30 years ago, but in today's terminology, that's what this desire was about. And what we had to realize, and I think this parallels also the realization that other actors in the global health space had, is that from initially a focus on infectious diseases, we needed to include non-communicable diseases as the disease burden constantly rises. We needed also to go from a focus of the global south, and Lars mentioned examples, to the global north, and really bring global back into the definition of global health. We needed to expand from a focus on predominantly rural areas, last mile, while that continues to be critically important, to areas where a vast majority of our population resides, and Lars gave the numbers earlier. And then we needed also to adopt our model from a model that was previously largely based on philanthropic donations to a model that we refer to as public-private partnerships, where there's shared accountability and not a donor-recipient relationship. But we need political will, we need strong politicians that define the priorities for the country, and then come together, private sector, philanthropy, academia, governmental officials, in order to define a shared vision, and then making sure we leverage our unique capabilities in order to support that shared vision. The work that we are doing together with New York and with other cities is credit to the Novartis Foundation. So this is not the main, I would say, Novartis organization, but we have the privilege of having a foundation led by Dr. Anne Ertz and her team. And a few years ago, we decided to shift the focus of the foundation to drive greater health equity in cardiovascular diseases, and with a very specific focus on cities. And initially, the team started to develop an approach, what we call cardio approach, where we holistically look into prevention through healthy lifestyle, into early detection, into the referral system that's necessary, and treatment and follow-up in a medicine agnostic way, but with a whole of city approach in order to drive that continuum of care. And the data, even in highly populous and resource-constrained cities, are quite impressive. Through this approach, we could triple the blood pressure control that existed in those populations, which as a public health physician, I couldn't believe at first, but the data really showed that with this sort of holistic, inclusive approach, you can get to very good blood pressure control rates. Extrapolated, that means a 10% reduction of strokes and myocardial infarctions. And this is truly important when you think about the population health approach in a city. The team have now put together a playbook that's been underwritten by the World Heart Federation and was rolled out and presented last night. But we cannot stop here, because we now have to go beyond that and look into the upstream social determinants of health. And that is where the foundation has partnered with Microsoft to look at the wealth of data that exist in highly developed cities, but sit in a very siloed approach to see how can we look at living conditions, education, nutritional conditions, proximity to healthy food, All of those elements that ultimately determine 80% of our health outcomes relative to the 20% that depend on the health care that we receive, and then work together with governments and city councils to make sure that the finite resources that the politicians can spend are being spent in an area that moves the needle the most with the view on better health outcomes or healthier populations. So it's been a very rewarding journey, but I think it's critical to the success that we bring a multitude of stakeholders into the fold and work together towards that shared objective.
Well, and one of the things that you're talking about that I think is so important and is great to hear, which is, you know, if you want to be effective, you need to not only leverage data, but you need to take an intersectional approach that takes into account the varieties of risk factors, whether that's gender, whether that's class, whether that's ethnicity or otherwise, and then identify interventions that can really meet people where they are. And you know, you talked about the continuum of care and you emphasized the importance of prevention, and I think this is something we don't talk about enough. We're so often focused on treatment, on cure, on reaction, without adequate or equal emphasis on prevention, and that's where I'd love to take the conversation next. Specifically, you know, ask both you as the Commissioner for Health in New York City, and then Lars, in terms of the research that you've done, you know, how do we make sure that prevention is prioritized alongside reactive strategies that are needed? And what is it that you would like to see in terms of prevention take place at the city level? So maybe I'll start with that, Ashwin, with you, and then maybe you can give us some examples in terms of your research of what you're seeing in that regard as well.
I'm so glad you're focused on this, because our partnership with AI for Healthy Cities, underneath Healthy NYC, we're also building something called the Health Planning Authority with our Office in Management and Budget, is all focused on this idea of how do we spend our resources against the things that are going to make the biggest difference on reducing mortality, preventable mortality, and extending life expectancy and health span. When you look across the leading drivers, every single one will index on prevention. And so Healthy NYC is a prevention agenda. We just don't call it that. But whether it's overdoses or suicides or cardiometabolic diseases or closing the Black maternal mortality gap in New York City, prevention is the key. And what we need is to impose a discipline and to shift the gradient of spending, at least amongst the resources that we can control in a city, if not influencing things like Medicaid spending through our waiver flexibilities or other forms of grant spending from the federal government, shifting that towards the things that are going to make the biggest difference, which will mostly lie in prevention, which will mostly lie in communities. And I want to lift up the other piece, which is if you're attacking premature death below 65, you have to deal with health equity. You actually have to center health equity. It's not an either or. Because who's dying below age 65 in most American cities, at least? It is communities of color. It's low income, low wealth communities of color in neighborhoods that have been historically disinvested in. So it offers up a frame and a discipline for us to not only spend on the right things, but to spend in the right places. Rather than sort of flying blind and leaning into rhetorical or singular research analyses, we get to say, as a city, at an area level, how do we actually start to move the needle? And I'm very proud to be partnering with my budget director on this, because without him, without his office, this doesn't really work. And it also brings these other agencies to the table, whether it's transportation or housing or our environmental protection agencies, let alone the private sector. It gives a frame, and it begins to shift that gradient of spending the way towards prevention and towards more community-based work, and out of the healthcare system where we're getting a lot of spending and frankly, few results.
Yeah, that's great. Over to you.
So what could we do in cities? So let's just do a quick journey around the world and as examples that are potentially, hopefully inspiring. So one that I like is the Physical Health Challenge in Singapore, where I think there's an enrollment of 25% of the population has been part of that. And that has materially led to people that had a sedentary lifestyle before actually getting into physical activity also when the challenge had stopped, so sustained results on this. Just an example, but a 360 approach, like all sorts of channels were involved, many stakeholders to get to that kind of change in a city. Another very different example, Seoul, which I think by some statistics is the fastest aging large city in the world, where there was a model to match the willing people who want to volunteer and participate in society, even at an advanced age, with opportunities to do so. And societal participation, getting out of isolation, is an incredibly important driver of health. So another, I believe, a very interesting example what is possible in a city. Let's go to the opposite end of the world, let's say places like Amsterdam, also some places in the US, where there have been successes with childhood obesity, also different stakeholders coming together in a city context to reduce obesity rates in children. But something that all of these examples have in common is that different stakeholders in a city come together, look at specific outcomes, mobilize around them, and deliver results. I think that's a great model. One thing, a comment on this, that the models to do that are different between cities. Sometimes the government is very much driving it more or less single-handedly. Sometimes it's a genuine, maybe across departments and so forth. Sometimes it's a genuine partnership between the public sector and the private sector, in equal share. Sometimes it's very private sector driven. Mm-hmm. So there are differences depending on what the infrastructure and what the setting in a city are. And that's something that we have learned from a McKinsey Health Institute perspective, that it's definitely not one size fits all.
Yeah, that's such an important point, that we have to really make sure that it's contextualized. We're almost out of time, but I want to end with one last question to all of you, and I'm going to ask you to be very, very brief, which is, if you could change one thing to help accelerate progress with respect to exactly this issue of strengthening health outcomes and healthcare at the city level, what's the one thing that you would first prioritize changing? I'm going to go, Lars, to you, ask you to be very quick, then Lutz, and then I'm going to give the final word to our New York City Health Commissioner, Ashwin.
Tricky question given this multifactorial and one thing, but to be honest, listening to Lutz right now, I think if every company every private sector company would put part of their attention on that, that would be a huge win.
Great.
Yeah, in my mind, it would be reframing the discussion from health expenses to investments into prosperity.
Great, fantastic.
I would invest the time in the leadership to develop unified health strategies for cities, and you can't do that without engaging communities as well. So I would make sure that that's centered in everything we do in cities.
Fantastic. Well, I think we have our calls to action, and thank you for joining us for this important conversation and for the work and leadership that you bring to these issues. Thank you so much.
Please now welcome to the stage Peter Sands, the Executive Director of the Global Fund to Fight AIDS, Tuberculosis, and Malaria, for a conversation with FP's Allison Carlson on strategies for addressing health inequities.
Thank you for joining us. Peter Sands, honored to have the opportunity to speak with you today. The last time I had this opportunity was a year ago, here alongside WHA. And within the last year, I don't think the health challenges facing the world have gotten any simpler.
Nope.
We've been talking about this morning the complexity of healthcare crises around the world and the impacts that conflict, climate change, and other issues are having on access and equity. And I'd love to pick your brain and hear from you about the innovations that are needed to address these complex issues that are continuing to evolve, and the ways in which the Global Fund is really working with partners and others to very targetedly and concretely address them. And so I'd like to pick up there and start the conversation about some of the partnerships that you have and that the Global Fund has when you're thinking about the prioritization of your investments and your partnerships. How are you approaching that, understanding that the issues are vast and complex, and equity issues, particularly in low and middle income countries, need specific and tailored attention?
Just a small issue to get us going. Can I start by just kind of dialing back a little bit to the genesis of the Global Fund partnership, which was originally created in response to the exploding crisis of HIV/AIDS in Africa. And at the time, there was virtually zero access to antiretroviral treatment in Africa. And people realized that the sum total of different government, private sector, civil society initiatives was not going to add up to a scalable response. And so the Global Fund was created as that partnership. And it's been an extraordinary story. At that time, antiretroviral treatment for a year for one person cost something like $10,000. As of last August, with the latest round of price reductions that we've negotiated with manufacturers, we're down to about $45 per person per year. I mean, that's an extraordinary difference. And we now have, between us and PEPFAR, well over 20 million people on antiretroviral treatment. So the notion that the Global Fund partnership is driven by addressing issues of health inequity and resolving them is nothing new. It was sort of central to the thesis of why the Global Fund was created, as is the notion of partnership, the fact that there's no one entity that can actually do this. You need the scientists, the private sector. You need a whole range of different partners like WHO and UNITAID and so on. And you need, in the field, governments, but also communities and civil society, because sometimes the people most at need are people that governments cannot reach. All this remains true, but what I would say is that in a way, we had a clarity of an overriding purpose in those early days, whereas now it's more of a multidimensional challenge. We have a whole array of innovations that can save lives and make a huge difference. We have a very complex array of challenges. You mentioned climate change, conflict. If I look at one disease alone, malaria, the epidemiology of malaria is changing very rapidly as a result of climate change. Getting products to the people who need them most is made much more difficult by the fact that there's a high overlap between the highest burden areas of malaria and conflict. And then you have both the parasite and the mosquitoes becoming resistant to established tools. But this is actually one really good example of what can be done. So mosquitoes have become resistant to pyrethroids, which are the insecticides used most commonly in insecticide-impregnated bed nets. So working with industry and UNITAID over the last 4 years, we've been looking at how to develop new generations. And the most effective of these is what's called a dual AI, a dual active ingredient bed net. And these became available last summer. And we have introduced with partners, again with partners, a revolving facility that allowed us to make advanced market commitments at scale, which allowed the manufacturers to bring down the price. And so now we have these dual active ingredient bed nets available. They're 40 to 50% more effective than the standard bed nets, and they cost only 70 cents more. And we have therefore seen a massive shift, over 60% of new orders, and we're over 50% of the world market for malaria bed nets. Over 60% of new orders are now for these new nets. So one can actually achieve very rapid access to innovation, but it does require a lot of different actors to be working in concert to make it happen.
You mentioned so many important points, and the example about HIV was fascinating at the outset about those rapid cost declines over a relatively short period of time and how essential that is for access and directly translating into issues related to equity. And the malaria situation, thank you for distilling that example. It dovetails with a conversation from earlier this morning when Assistant Secretary Pace was saying the mosquitoes are winning. And you're noting the evolution of these complex issues and threats to global health, but also the rapid response that's capable. And I appreciate, too, the specificity regarding the mechanisms that enable that cost decline in manufacturing. You mentioned advanced purchases, for example, that then allow the manufacturers to reduce cost and then to be able to distribute to the last mile. Can you provide some other examples of those kinds of mechanics that, whether it's from procurement or otherwise, that are enabling those kinds of cost declines and delivery to the last mile, especially for, in addition to issues like malaria, either TB or others that continue to be evolving and chronic issues around the world?
First, having clarity of demand is absolutely critical to manufacturers, right? If you're investing in a manufacturing line, you need to have some sense of, can I count on this being something that I can be producing and selling at scale? So that's where advanced market commitments become really important. Another one, and I'll use the BedNet example again, is there's an enormous amount of actually, when it comes down to it, unnecessary variation in in different countries' requirements. So you might think that insecticide-impregnated bed nets are all the same, but they're not. Countries demand different measurements, different colors, different ways the hooks are affixed. And so one of the big challenges we had was working with both the countries and the manufacturers to work out what was the price premium, or rather the opposite. How much cheaper could we make it if we could get all the countries to basically have the same net to the same dimensions? And surprisingly, roughly speaking, most people are roughly the same size, so it should work. And that was one of the big things. Now, for different types of products, the nature of the the cost drivers are different. And one of the things I think we've learned is that we've got to engage with the manufacturers in that discussion. So we understand what's driving their costs so that we can then work with the countries and the people delivering the services to say, how much can we do things in a way that really drives down the cost? I do want to emphasize, though, that cost is one driver of equitable access, but it's not the only one. All the issues around regulatory approval and guidance are absolutely critical. And this is challenging because we don't want WHO to compromise on the rigor of its processes, but on the other hand, we want those processes to be timely. And that, because countries find it very, very difficult to introduce new products if they haven't got the appropriate approvals and guidance. In fact, they can't. The third point I'd make on equitable access is it's one thing to get it to the countries. The next thing is to get it to the people who need it most. And one of the challenges we still face, particularly with HIV, also with TB, and to some extent with malaria, is that you have marginalized populations, those who are discriminated or even legally or just by social stigma, who, even if the product is in the country, aren't able to access it.
What do you feel like needs to be prioritized to bridge that gap and that last mile challenge that continues to be pervasive throughout the world, especially in low and middle income countries?
Well, the complexity here is that the answer isn't the same by country and the answer isn't the same by disease. So I think you have to start with what delivers the outcome. You have to say, what is the thing that is stopping life-saving or effective preventive treatments getting to the people who need them most, and literally focus your effort on the blockage or the obstacle that is most pressing. So if I take HIV at the moment, in many countries, we have seen national AIDS programs, community, civil society do a fantastic job at expanding and sustaining treatment. The big task now is improving HIV prevention, stopping the flow of new infections. However, that isn't going to work if you have human rights and gender-related barriers stopping the people who are most at risk of infection accessing those products. Even, we've got some great new products. We've got Cabalé, the long-acting PrEP. We've got the vaginal ring. We've got a range of new tools coming down the pipeline. But if the people who need them can't get them, so for HIV, I would say much of the issue is around actually the non-biochemical, biomedical things. It's around the policy related issues. For TB, we've been putting a lot of the focus on the costs because actually TB is structurally underfunded in most parts of the world. It's not a very glamorous, I mean, you could say no diseases are glamorous, but some are more glamorous than others, and TB is definitely not high on that list. And so during the course of last year, you saw a 20% reduction in the price of GeneXpert cartridges, critical to the molecular diagnosis of TB. You saw a 55% reduction in the price of bedaquiline, the key component of most drug-resistant treatments. You saw a 30% reduction in the price of the preventative treatments of TB. So we were very focused because cost has been a critical impediment. Malaria at the moment, frankly, and Lois Pace's comments, I hadn't heard, but I'm sure I would agree with. We're in a very, very challenging situation with malaria at the moment, and we have to do multiple things at once to meet the combination of resistance, climate, conflict challenges that are facing us.
So in the minute or so, not even that we have left, we're excited about the market-shaping innovations you've discussed, the ways in which partnerships are driving down cost, addressing issues of equity and access, and we'll dig into access a little bit more in a few moments. In this moment, here, this year, what are you heartened by in terms of what's being prioritized, and what would be your call to action to those in the room and outside about what needs to be done to catalyze action and equity?
Couple of things. One is a general point about speed. I'm not a scientist or a clinician, so I'm a bit of a imposter here. I come from the world of finance and economics, and in the world of finance, people talk about time is money, and basically there's a basic logic that if you can do something faster, it's a better thing to do. And in this world, time is lives. If we could do things faster, we would save more lives. And yet, we often do things in the global health world quite slowly. And so one of the lessons I've learned from the COVID pandemic, but I'd like to see happening more in the way we fight existing diseases, is let's just kind of cut through stuff faster and get the guidance, get the regulatory approvals, get the product into country, get the in-country obstacles ironed out just faster, because in most of these diseases, there's a weekly death toll in the thousands. And if you can be reducing that, you're saving lives. So that would be my overarching comment. There is actually no shortage of innovation. Across the diseases we deal with, there's a ton of innovation. It's just how do we move it faster to get to the people who need it. The second thing is, I would say, is always keep focused on the outcome. Sometimes we get excited about the tool, the process, the institution, but actually, if it's not reaching the people, if it's not saving lives, if it's not reducing infections, not reducing morbidity, then frankly, I'm not very interested. It's actually got to be having impact at scale.
Very well put. Thank you for your work, your distillation of those issues, and talking about the accelerants. What can be catalysts here in terms of action, and what are the kinds of partnerships that can be streamlined to drive that impact? So thank you for your work and sharing your time with us today.
Thank you very much.
And now, a conversation on how partnerships can increase access to medicines with Dr. Susana Almeida, Secretary General of the International Generic and Biosimilar Medicines Association, Aleph Muhlenberg, founder of Regiza Bubulali, and Lisa Hedman, World Health Organization Senior Advisor for Access to Medicines and Health Products.
Thank you, everyone, for joining us. And this conversation is very well timed and well programmed to the team, coming after Peter Sand's comments about catalysts, about impact, and about what actions now will actually have transformative impacts on people's lives, because time is short and people are dying every day. And one of the major issues related to that access and equity is access to medicines. And so that's what this conversation will be focused on, and the ways in which different organizations, international organizations, civil society, private sector can really work together, again, as we were just discussing, to streamline those activities and make them more efficient to drive near-term, faster impact. And so, Lisa, I'd like to start with you. What we've also been talking about today is increased demand and decreased funding. And when you're thinking about the role of the WHO, and specifically as it relates to access to medicine, and when we're seeing data come out of the World Bank where the number of countries that are actually reducing the amount of investment in public health, how do you reconcile those things, and how is the WHO thinking about it as it specifically pertains to access to medicine?
Thanks so much. I think that there are a number of things that we have to think about as we move through this week at the WHA. A lot of initiatives will come forward that shape what WHO does in our global plan of work. But one thing we know for sure is that access to medicines will continue to figure in a very, very prominent way. It's also important that we sort of listen to all of the things that the people before us have said and recognize that access is actually a fairly complex chain of events that need to happen. They need to come together to actually form an end-to-end approach. And one of the things we like to do is say, well, how can we summarize that? And when we think about a person who's trying to access medicines, it comes down to affordability. It comes down to accessibility. Can they get it? And it also comes down to acceptability. Is it something that actually can be made to work in a particular context? So you brought up equity, and equity is another component. And equity can look a little bit different depending on the context. It can be an emergency context, or it can be something that's an ongoing situation. But at its core, what it speaks to is that we have an environment where all people have those three dimensions, that it's accessible, affordable, and acceptable. And as Pete was saying, investment is critical. And investment has a huge impact on whether or not something actually goes forward as business as usual, or if it's accelerated, it gets there faster, it gets there to more people. What is it that the investment is trying to do is a critical question. But I think one of the things that we have to think about, and one of the tough questions, is that investment can happen at any part of the value chain. It can happen at the manufacturing level. We talk a lot about that. We talk a lot about that in terms of medicines that are in shortage. We also talk about investments in supply chains, and we talk about investments in what we often call the last mile. We have to remember that for the patient, that's actually the first mile. So depending on your perspective, that can be different. So investment can happen anywhere. But one of the things we are very sensitive to is that there are situations where there really isn't investment. There may not be sufficient investment, there may be no investment. And I just want to use an example of something that we don't talk about very often. There are, for example, rheumatic heart disease. This is something that actually can be prevented with a very, very simple, very inexpensive antibiotic. Yet that antibiotic is hard to find. It's benzathine penicillin. It's not a blockbuster, but it's been running around in shortage for almost 10 years. And so when you think about 40 million people who are affected, disproportionately young people, disproportionately women, this is something that can be fixed, but it is going to require investment in all of those aspects of the supply chain. We also have countries with limited purchasing power. That's another place. So when the country system itself can't uptake these innovations, as our other speakers were talking about, this actually is another kind of problem. So we have to think about, well, how do we combat that? There's lots of different things that can happen. One is pool procurement. That's not easy. It sounds really great. It's not an easy thing to do, but we do have examples. There's a group of countries, the small island developing states in Africa, who are coming together to create a pool procurement mechanism. But it's not necessarily about driving costs down. It's about having access to that quality assured market so that what you are purchasing is of quality, and it's going to actually treat that person who takes that step to walk up to their first mile to access those medicines. So stabilizing the market for them is a little bit more important than actually lowering the price. So I do want to just say one thing about all of the partnerships that have been discussed here. And just to be really realistic, there is no one entity that can do this alone. There isn't. It's just not realistic. And so when you think about partnerships and how important they are in that access value chain, we think about regulators who rely on procurers, who rely on research and development, who rely on clinical guidance, who rely on, you get the picture. It just keeps on going on. And so thinking that any one entity can manage that alone is just not reality-based. And so we really do need to make sure that when we develop partnerships that we act on them, that they're strategic and that they work well. I really appreciated Pete's comments. WHO partners with Global Fund, Gavi, other UN agencies. Those came up during COVID with the ACT-A partnership with COVAX. Those were some pretty tough times. But without those partnerships, the good things that happened wouldn't have happened. We all know about ways to get things from those innovator companies into generics. We partner with the Medicines Patent Pool. Those things, again, they can happen in tough times, but a lot of good things can still happen. I know a lot of the speakers are coming together here for the first time, and we're really grateful for that, but I'm not going to pretend that I don't know Susanna. And I want to just call that out because that's a key partnership. We also have collaborations with industry that are extremely important. If we don't collaborate with industry, the approach that we take, even when we try to piece all those bits together to say this is what access looks like, it's got to be sustainable access. So really grateful for that, and thanks very much for that question.
Yeah, and thank you for joining us and providing that framing for this conversation. And for introducing Susanna, I'd like to turn to you next, and it's a great segue. It's important to talk about access through the value chain, as you are noting, Lisa. And Susanna, from your perspective, you have extensive experience in generics and biosimilars. And when you're thinking about the industry's role, how are you conceptualizing that as it relates directly to your work in issues of access specifically, and then the kinds of partnerships that are driving impact, and appreciate the reality check and wanting for candor here. What is working? What isn't working? And what can we learn from your experience?
Thank you very much. IGBA, we're the International Generic and Biosimilar Association, and we work to represent the various generic and biosimilar associations across the world. Our role is to strengthen the collaboration among them at the local and also regional level, and represent the generic and biosimilar manufacturers around the world. We work to enable innovation and access to improve access to quality assured, safe and cost-effective medicines to patients all around the world. And we do that by advancing the global efforts that can improve access to medicines by, for example, promoting the regulatory cooperation and international convergence, which is extremely important, namely the harmonization of standards, to have balanced and robust intellectual property systems that foster innovation and maintain the sustainability of the medicines manufacturers. This is all, of course, in the best interest of patients and the health systems, because that's what essentially all of us around the table and here during the week are trying to achieve: get the patients to get the medicines to those who need the medicines. Our industry supplies the large majority of the prescription medicines to most patients around the world. We've heard in the previous session a great example of this regarding the access to medication for TB, malaria, and HIV. And generic manufacturers and generic medicines have enabled to get treatment to those conditions to millions of patients who are living in lower and middle income countries. So what we have is unique experience that is helping us identify barriers to access, and we seek to help create innovative solutions that will improve the access and meet the needs of also the health systems. When we talk about universal health coverage, that will not be possible without timely access to these life-saving therapies and affordable and quality-assured medicine. So I think this can only be done through partnerships. One of the things that I keep hearing in all of the conversations this week here in Geneva is that we all want access to patients, access to medicine and treatment and healthcare to patients. But what that means to each one of us is really not the same. So making sure that we understand each other's perspectives and come together to find solutions that work, I think this is the key that we can help unlock with our conversations here and continue to develop throughout the year. So this does not end here, it begins and continues here, but the real work that we are doing is done throughout the year. Because in essence, while as organizations and stakeholders, what access means to us might be different in the end. I am a mother, I am a daughter, and what access means is when one of my family members is sick, getting access to the treatment that will help make them better.
One quick follow-up question to you, and then Alef, I'd like to turn to you about community-based experience and the lived experience on the ground. But a quick follow-up to your question as it relates to generics and biosimilars. You know, there have been has been an evolution of manufacturing trends around the world. And as you said, distribution is incredibly important to facilitate access. What can you say about those trends around the world to ensure greater manufacturing around the world in different hubs so that there can be more streamlined distribution in places that need more access?
I think here when we talk about this, it's important to understand that one size is not fitting all, and we really have to see what makes sense in the different geographies, in the different contexts, to understand how we can help make that access possible to the patients. So it's really my message there is we don't have a one size that fits all.
It's an important point to remember. And you've both made really important points that lead me to you, Alef, in terms of the first mile, the last mile, access to medicine. And the experience that people are having who don't necessarily have access to the medicines that they need. And you've been doing tremendous work on the ground in that respect. And so I'm wondering if you can share your perspective in the work that you're doing about the relevance, the urgency of these issues in terms of access to medicine.
Thank you. So at RESA, we solely focus on the last mile. So our aim is really to start clinics in underserved areas where there's no access to healthcare nor medicine in general. Or if there's access, there's limited access. So I'll give an example. A township in Johannesburg, South Africa, called Diepsloot. It has anywhere between 100,000 and 1 million people. I know it's a very broad census, but no one really knows how many people live there. But there are 2 government facilities that provide primary health care to those people, and it's not enough. People queue there from 5 in the morning and often are not seen, and therefore have limited access. So we built a clinic there as a satellite to a public healthcare clinic. And by doing so, are able to provide life-saving care based on HIV treatment and care, based on TB treatment, but also based on preventative sexual reproductive health care that other people otherwise wouldn't have access to. Why is that interesting? Is because here you have a public-private partnership where government buys ARVs from Viatris, for example, who is a partner of this conference. They buy that at a reduced rate because they have a deal with Viatris, but at the same time, the government gives us those ARVs so that we can provide them to patients. But we are a private clinic, so we make patients pay a minimum fee for it, but that reduces the cost and therefore creates more sustainable models on the ground that can lead to access to medication. Another thing that's important to note is that not everything needs a doctor at the last mile. So for us, having community health workers, having nurses, having nurse-led clinics, again, reduces the cost to the end user, to the patient in this case, and then therefore ensures that there's higher levels of accessibility and higher levels of affordability when it comes to those services. So for us, those 2 components together, on the one hand, access to medication, and it can either be through partnerships with one of pharmaceuticals directly, or it can be in a public-private partnership with integrating our clinics within a larger ecosystem, health ecosystem. The other is to ensure that the affordability for the patient is as low as possible. And so those are 2 ways in which we do that. Then more on a preventative front, I think a lot of people underestimate the importance of sexual reproductive health care services because it's difficult to do. And it's difficult to do because there's a lot of, as been mentioned before, there are a lot of taboos around providing sexual reproductive health care services. So things that we do is we link our clinics to a sports facility. On our mobile clinics that we have, we build a basket on top of them so that the kids that we engage with, their defense levels drop because they're engaged with sports, and then you can engage around more difficult topics like sexual reproductive health. So innovation doesn't always have to include technology. It can be simple things like that, but it really is context-driven. And those are, I think, 3 main points for us as to how we provide more access to primary healthcare in general, or community healthcare, and then link that to relevant medications.
You raised so many important points about context mattering, of course, and needing to design, craft, and tailor engagement in ways that are appropriate for the communities in which you're engaging. So thank you for that, as well as underscoring both the role of frontline healthcare workers, community-based workers, and the importance of sexual and reproductive health and rights. I agree with you absolutely. That is an issue that is often taboo, not talked about, not well understood or researched. And so more work can and needs to be done in that respect because of the compounding impacts on women's lives and families, et cetera. So thank you for those concrete examples. I'd like to turn to both of you, Lisa and Susanna, from your perspectives. I appreciate, Aleph, what you said about the components of partnerships that work and understanding everyone has a distinct but differentiated role to play. What would you both, from where you sit, point to as some of the key components that enable that alignment? Lisa, first to you, okay. And then Susanna to you.
Thanks so much. And I'd like to answer that question just in the context of an example. One of the things that's come up a lot is this issue of diversity, and it came up after the pandemic. Should we diversify the supply chain? And that would mean moving to things like local production of medicines. And so when you think about the partnerships that would have to come together for that to work, you have to really start with saying, what's our common goal? And when we're dealing with the public health agency versus an industrial company versus a community activity, they can always feel very, very different. So when you get to that place and you say, well, we're not in the same train, but we are going the same place, and be really clear about what that place is. That's one of the most critical things. But I think the second thing that's important is to really be clear what needs to happen. Because if you skip a step, you don't achieve it. If you try to do everything at the same time, it starts to get a bit convoluted. Everything's a priority, but we can't do everything all at the same time. When you've got a mountain in front of you, you actually have to figure out which piece of the mountain you can bite off first so that you don't fall apart. So being strategic, making sure that you don't miss things, but particularly really making sure that you align on what that common vision and goal is, regardless of how you're going to get there and which piece you own. That's, to me, I think, one of the most important things.
And Susanna, for you?
Yeah, from my side, I think the main aspect is that we have to talk to every chain, every link of this chain. We have to understand people's perspectives, no matter where they may be, because coming back to my previous point, access does not mean the same for everyone, and understanding what are the challenges that each party is dealing with will help us come with solutions that can address those challenges. I think the partnerships may be seeking to address things and make systemic changes. For example, our long-standing cooperation with ICH, we're a member of ICH, where we work towards international harmonization. That's one side. But also the immediate needs, and here I'd like to highlight the excellent work that has been done by our member associations and affiliated companies, where they are seeking to help provide medicines to those in need, for example, during emergencies. And this is also super important because the two are needed if we want to make sustainable change. I think one very element that is important in any partnership is that we have an open forum for free discussion, that we are engaging, that we are explaining our challenges, and we are seeking together ways of overcoming them. And engaging, for example, with stakeholders like WHO, where we're looking for solutions together. This is of paramount importance. This can actually make a difference in people's lives, and we can find ways to help address issues like what Lisa was mentioning before, the resilience of supply chains, for example, which is very important. And we are really thrilled with the opportunity to do this work together and to work collaboratively to reach solutions that matter. We're very committed to coming to the table, identifying things that we can do now to advance these collaborations.
And how the conversations and opportunities here today with everyone in the room are so important to achieving that. It reminds me of a conversation from earlier in the program with our friends at Essilor, who were kind of calling on all of us to think about the bold and kind of surprising types of partnerships that can really drive impact that's needed. And so, Aleph, I'd like to turn to you in the final moments of our segment here. When you think about those partnerships and being able to make those connections that are needed from the local level upward in order to ensure that last mile delivery, what are the key factors for you that may not be well understood or appreciated from those elsewhere in the value chain?
I think for me, access is absolutely key when it comes to primary healthcare, and access in a way that doesn't interfere with people's lives for an 8 or 9 hour waiting period of time. So ensuring that there is adequate access to medication, to vaccinations for children, to consumables when it comes to sexual reproductive health, to PSA tests when people get older, and particularly with men, we now do tests in order to test them for prostate cancer. All those kind of diagnostic tools that can help on a primary healthcare level to reduce the burden of care on a secondary level. I think for us that is absolutely key when it comes to achieving better health outcomes as a whole. When I think about 60% of South African pregnancies that are still unwanted today, then for me those stats are alarming, but at the same time something can be done about it. But it can only be done if the right diagnostic tools, the right medication and the right levels of care at a primary level and at a secondary level come together. So players in those area industries can collaborate with the likes of the WHO, but also with the likes of partners underground like ourselves, who are expanding our clinics on a monthly basis to reach more people. And I think for me, that's key.
Yeah. And as Peter Sands was saying earlier, really keeping our focus on the impact. What are the partnerships that are driving impact? How can we focus on those, streamline those to really accelerate and catalyze action? Appreciate all of your work and also elevating the different roles and responsibilities that organizations and that we all have to play, and lifting up lived experience and what is happening in communities on the ground. In order to showcase that and to end on a positive note about the work that you're doing, love to share a video that encapsulates some of your work in South Africa and how that can be applied elsewhere in the world. So thank you all for your work, and if everyone could turn their attention to the screens.
My name is Uleboheng Mumakwe. This is Diepsloot. This is my home. It's overpopulated. We've got more than 400,000 people living here.
Where we stay, there's no electricity, and the toilet, it's on the street. It's not healthy. It's not safe.
We've got 2 public clinics. You have to queue there from 5 until 3. We don't have a hospital, and we've got us. You need health to create a thriving community.
When I hear nurse, I hear caring, I hear love, I hear uplifting, I hear giving someone else a chance. It's about hope. Community nursing is important to me because I feel that we're part of the community. We understand, and yes, we are the first line of defense. We are also the protectors of the community.
Thank you, everyone.
Ladies and gentlemen, please welcome Foreign Policy's publisher Welcome to the stage Roland Dries, International Affairs Director at the Ministry of Health, Welfare and Sport, Government of the Netherlands. Dr. Atul Gawande, Assistant Administrator for Global Health at the U.S. Agency for International Development. Dr. Sonia Nishtar, CEO of Gavi, the Vaccine Alliance, for a conversation with FP's Andrew Solinger on global health security.
Thank you all for your attention and focus. Can you hear me? Great. For your attention and focus all morning long. I'm so impressed with everyone still in the room. Standing between you and a delicious lunch is this discussion, so we'll be very succinct and on point. And boy, do we have a lot to talk about. I'm really excited for this closing panel today, talking about global health security generally and some of the big initiatives underway. Atul, I'm very excited to chat with you. The last time we spoke was 2 years ago at a FP Global Health Forum, and you were brand new to USAID. I'd love to chat about some of the things that you've learned over that time period. It's been tumultuous, and you've just launched the U.S. Global Health Security Strategy. Would love to talk about that. Dr. Nishtar, Sanya, if I may, thank you so much for joining us. You're brand new at Gavi, so we'd love to hear a little bit more about what you've discovered in your first few months on the job and the 5-year plan that you're rolling out, of course, for Gavi going forward. But Roland, we'd love to start with you. It's been a tumultuous week or two focused on the pandemic treaty. You are, of course, the person who sits on as a co-chair of the intergovernmental negotiating body. And we want to talk to you a little bit about what has happened with the pandemic treaty and next steps. But I wanted to reflect on one of my favorite programs recently. Many of you may have watched it. It's called The Three Body Problem on Netflix. Familiar with that one? A fantastic story and a fantastical story of humanity faced with an alien invasion. But the key element of it is that the aliens aren't going to, they're light years away. They're not going to invade for a couple hundred years. So we have a long time to work together and plan our mutual defense, share intelligence, share tools, the West and the global South, so that we can, as one united humanity, defend the Earth. Does that sound familiar? It doesn't work in the show either, by the way. So we're not going to spoil any of your endings. I don't think I've killed that for anyone. But I didn't come up with that analogy, by the way. That was written by Luke McDonough, who is a law professor at the London School of Economics, and he wrote a piece for FP called "Blocking a Fair WHO Pandemic Accord Endangers Humanity." And that without an equitable agreement, including wealthy nations sharing IP with poorer nations, the world is doomed to repeat its COVID-era mistakes. We published that 10 days ago. For those of you watching online, you can see the link on our site, but please do visit fp.com and read it. It's a worthwhile read. So not sharing doom and gloom as much as here's where we are. You've spent a lot of time on this, Roland, and as we just discussed, we came into this week knowing where the treaty was. What I'd love to hear is a little bit more about what you think the next steps are. Is this something that we have to restart? Are we midstream right now? Is it something that can get done? What happens next?
Is this working?
I think so.
Well, firstly, thank you for spoiling my flight back home, because I was actually going to watch the 3rd episode of The Three-Body Problem. But I'll do that anyway, because I trust that it has some learningful experiences for our work in pandemic prevention and preparedness as well. We've been working on this for the last 2 years plus, and we started with this work in the aftermath of the COVID crisis, because we all felt that it was the logical thing to do. We were all in a situation which we hardly had ever encountered, that there was a disease spreading around the world. It's not just in Africa or somewhere else, but it was really everywhere. And it was occupying our minds in all countries of the world. So it made so much sense to come up with an ambitious framework, legal framework to better cooperate. And we started with a blank sheet of paper, and people forget that. And if you see where we are now, that is far beyond the blank sheet of paper. We have the whole story written out on paper. I think all the elements that matter to pandemic prevention, preparedness, and response are written down. And people might say, oh, this is not committing enough, or this is not strong enough. But I think that all the critical elements are in there, but we just did not have enough time to really agree upon them and finish them. And why is that? Because some of the issues in there are sticky, especially on the crossroads between public health and economics, public health and human rights, public health and trade, public health and, so many issues where there's a cross-cutting connection between public health and other fields of interest. And we just did not have the time to solve them all, actually. And that is not surprising, but it's maybe disappointing for people who are a bit further away from such processes, but normally they could take 5 to 6 or 7 years, and we try to do it in just over 2 years. And that has proved to be too ambitious. So now, as we speak, at the World Health Assembly, countries need to decide on the next steps. And I really cannot believe that there will be any other outcome than a continuation of the process. The only question is, for how long? Will we try to do it in 3 months, 6 months, 1 year? That's the discussion, I think. And let's see that will bring us.
Thank you for sharing. And I just want to reconfirm that I did not ruin the program for you. You'll get a lot out of it after episode 3, Three-Body Problem. What if you were to do over again, starting with that blank slate and a compressed timeline, which everyone would agree with? What kind of thing do you think we could have addressed and people that we could have brought to the table either sooner or better? There's so much discussion around public-private partnerships. We were just discussing this in a few previous panels. Could the private sector have been engaged more fully at the table earlier on? How are we going to overcome this key critical element around IP, which seems insurmountable? We have Lois Pace here talking about this a little bit earlier. How do you address that and get at it, and what could we have done earlier on in this process?
Well, it's obvious that for those kind of issues you need a private sector, and the private sector is an ally in getting there. That's, at least for me, that's pretty obvious. And we've spoken to them, and they've spoken out as well, and they've also indicated that they're willing to consider set-asides, for example. But they also said, and that's their good right to say that they feel that intellectual property rights should be upheld as much as possible. And well, that's just a given. But I think this is what we try to do, is create a treaty between 194 countries around the world. And then it's not easy to bring in the private sector in those discussions, because countries want to be in control of what they decide. And you can bring in private parties as advisors or partners, whatever, but not, it's just in the way we do things now, it's not possible to bring them in on the table and be equal to countries who are going to sign this. It's just not the format we work in. And would it be better? Well, that's another thing, but it's just not what we do.
Right, okay. And time is of the essence, of course. You have, and I know you're not telling us any specific timelines. Will it take 1 to 2 years, hopefully not 6 or 7? How much time will this take, do you think, is in your best estimate? I know there were discussions around that this week. What can you share?
Well, firstly, it's not up to me. It's up to all those countries in the World Health Assembly to decide upon a timeline. But I think that something between a half year and a year, we should be able to do it. And like I said, we have all the elements. We all know of all the critical aspects to be decided upon to do this. But I think that maybe, that's my own interpretation of things, that expectations were sometimes risen too high. And like if this treaty is there, then all those problems around pandemics will be gone. And that's of course not what's going to happen. It is like what Mike Ryan from WHO said. It's just a starting point. It's a platform. It's a structure for further cooperation between countries. And let's see that it's unique that 194 countries say to each other, preventive policies, One Health, those are critical elements, and we should work on them. But do always in the understanding that there are countries out there that do not have the capacities yet to do that, so they need to be helped. But don't think that everything should be full-fledged at the moment that this treaty is signed. It's a starting point to improve the world in the next 25 years.
And what seems to be encouraging is that the will is there, so
yes.
These problems can be solved.
Yes, but at the same time you see that it's maybe difficult for some countries. To give you the example of the set-asides, the percentages of vaccines that should be put aside by the pharmaceutical industry to be shared with countries in most need. Well, that's a very sensitive issue, as you can imagine, because that is something you say to private partners, you shall be setting aside a certain percentage. They do that on a voluntary basis because they also believe in the system, but that's very unique. And but if you need to come home and say that they should be setting aside 20%, for example, and it's only 5%, then that might be a disappointment. And again, I think you should not look at it that way. You should look at it as a starting point for cooperation. So if every country, and this is just one example, and they are across the board with all countries in the north, west, east, south, they all have those kind of issues that they expect from this. But if you keep up those expectations too high, and you run the risk of being disappointment that it's not that yet, then it's going to be difficult to agree upon. But if you all see this is a starting point, like I said, then it can be done within half a year to a year.
Great. Better living through low expectations, my mother always told me, so that is a good word to live by, I would say. Sonia, would love to move over to you and bring you into the conversation. As mentioned, you've only recently taken the helm of Gavi at a critical time. You know, we're talking about this right now. Would love to hear how it's going, your experiences with this, and if you could, move into the 5-year plan that you've developed for Gavi as well. Please do share.
Well, first of all, thank you for having me here, and it's great to see so many friends around the room. I'm 9 weeks into the role, brand new, and it's felt like moving on a jumping train because the organization is at a very important inflection point. I have our respected board member on my left side who will bear me out. We are on the road to what we call replenishment. It's in our parlance, it's the name for our fundraising drive. We're fundraising for the strategy period 2026 to 2030, and alongside we are also shaping a new strategy, an ambitious strategy. It's taken Gavi to immunize 1 billion children in 24 years since it's been an inception. And our aspiration is to vaccinate the next 1 billion in half that time. So we're preparing for that. And part of my role as an incoming CEO is to prepare us for that accelerated phase. And in that accelerated phase, there are new vaccines in the market with no shortage of supply, vaccines such as the human papillomavirus vaccine, the first against cancer, transformative potential. There is the malaria vaccine with no shortage of supply, and there is the tuberculosis vaccine on the anvil, and all this alongside the routine childhood vaccines, which is very much the bread and butter of what we do. So many vaccines and others on the anvil, an ambition to vaccinate the next 1 billion in half the time. But we are doing this against a backdrop of a very resource-constrained environment, where there are conflicts ongoing, with climate change is a reality. The traditional donors have their own macroeconomic challenges, many internal competing priorities. And of course, this is a world where the viability and the usefulness of the multilateral system is unfortunately being questioned. So it's a time of great transformation for the organization. And as the incoming CEO, I, of course, had to immediately jump on these two processes. And as any CEO of a large ship would, I've had to look internally, look at the HR matters, the financial matters, make a 6-month plan for myself, which has some very exciting components as well. The plan is in the final stages of being shaped up. I will take it to our board. My colleagues have to weigh in. And I think this is also a very exciting week for us, because we are looking at what's happening at the World Health Assembly. Our respected co-chair talked about the process, and we have to be optimistic about it, because the pandemic treaty actually has to provide the rules under which all of us are going to operate. That is going to be the overarching framework under the rubric of which we will play our respective roles. Gavi, for instance, the bulk of our work is routine immunization. But the system that we develop in that process is the system that is going to be leveraged when a pandemic happens. And we are very conscious as an organization that we have, for lack of a better expression, 4 different roles in that emergency scenario. One is, of course, the routine side of vaccination and building those rails, building that system which will allow us to deliver. The second is to have financing available on day one. And to that effect, my predecessors did a very good job of structuring an instrument called the Day Zero Financing Facility, which we've designed, we've structured, we've fundraised, set aside the money, and we will be taking it to our governing body for approval next week. The third role that we have to play within this framework is to learn lessons from what happened during COVID. And during COVID, there was a huge trust issue with regards to the access issues that the African continent faced. So as an organization, Gavi learned from that, and we've put together what is called the African Vaccine Manufacturing Accelerator, which is basically an advanced market commitment of $1 billion meant to act as a catalyst to signal to the industry that they must come forward and invest. That again has been structured. The money has been raised, put aside.
You're launching that in a few weeks' time.
We are launching it on the 20th of June in Paris. And again, the final structural modalities of that in terms of the governance, in terms of operations, in terms of treasury management is what our board is going to hopefully approve next week. And then the fourth part, which I think Gavi has to play, and again, let me re-emphasize, it's an ecosystem of actors, with the treaty being the overarching normative framework, with WHO as the steward, and many of us having different roles. We are one of the many. But the fourth important role, as the vaccine alliance that we play there, is to actually manage the vaccine platform in case of outbreaks and emergencies. Now, those outbreaks could be outbreaks where the pathogen is known, and we already have a stockpile. Those emergencies could be an outbreak where the pathogen is known, where the vaccine is registered in one country, but is not pre-qualified by WHO. And the current Mpox outbreak in DRC is a case in point. And in those situations, what is the role of Gavi? The third situation is where there's an outbreak and the pathogen is known, and the vaccine is very much in the upstream stages of development. So what does Gavi do to accelerate? And then there is a disease X situation. So I know you sitting up in your chair as a way of signaling to me that I should round up, and I will do in a second. So you know, as a presenter, you have to be very conscious about body language from the moderator, but
You're going to be a great CEO, I just want to say right now.
So just to close the loop, just to let you know that what you're doing is very important for us, because we are one small entity with, as a CEO, I look at our role in the pandemic landscape across 4 dimensions. And I want to have clarity on how we're going to play the role. So I'm going to make a control room with clear SOPs pasted on the wall, ready for us to move into the control room and switch on the light and know exactly what to do when WHO gives us the call as per the framework that you set in.
By the way, we could have gone on for a very long time there. You were doing great, but we only have a few minutes left. We'll move on to Atul.
And my board member can't.
So one of the key leadership roles that we all have, of course, is hiring smart, brilliant, driven people. So kudos, Atul. You've definitely done a great job there. And want to bring you in and talk a little bit about, first of all, as I mentioned, we last spoke 2 years ago. You were the new person at the helm then of USAID and the health strategy. This was a COVID conference we were having. Everyone in the audience was masked. Look at us now. Vaccines, again, playing an important role in that. And you wrote a fascinating piece, I thought, in the New York Times, I wish it was published in Foreign Policy, about how the world needs its own immune system. And I would love to talk to you a little bit more about what you mean on that, pull that thread, but also what you've learned in the past couple of years at USAID. You mentioned in that piece that you've just gone from crisis to crisis to crisis. Are we in a perma-crisis right now? And is that the normal state of affairs that we have to prepare for? Please tell us your thoughts.
Well, so yes, came in to help drive the response internationally on COVID, and then it turned out we've had 6 Ebola or Ebola-related outbreaks, so 3 Ebola outbreaks, and then the cousin of Ebola, Marburg virus, up to 90% mortality, no vaccine, no diagnostic, no treatment, and on top of that, Mpox, another public health emergency of international concern, and 30 cholera outbreaks, polio returning to Malawi and Mozambique to Africa. Yes, the pace of outbreaks are increasing, and so all the while that the pandemic negotiations is going on, in fact, the system has been evolving, and you are seeing ways in which
Our body has an immune system that detects threats, rapidly responds, and interestingly gets stronger with each subsequent threat as it builds its library of response. And that is exactly what has been happening in the global community as we go along. The system has learned. It is imperfect and there are continued challenges, but we do get stronger and better. And as a reflection on this, recall Ebola outbreaks were killing hundreds to thousands of people as recently as 2018. In the DRC, where that outbreak in 2018 killed north of 2,000 people, the responses in the year following that meant that instead of virus circulating for 4 months before detection, it was just 1 month, and it was 55 dead. And then in April of 23, it was just less than 48 hours to have a response, detection, and then follow that with a response, and it was 5 dead. That kind of extraordinary pace of change, that is because of international commitments, whether it was WHO, USAID, CDC, in particular making investments to strengthen laboratories, build emergency operations centers, control rooms going into organizations and governments all over the world. And we have played a critical role in the US government in trying to align with the world's views of where that response what it should look like. But what I would say is the strategy around the world is largely agreed upon. The work that is happening in the court is a lot more about how do you make it happen. The mechanics, who has what responsibilities and so on. And yet the whole way, what we now know is within 24 to 48 hours, we have to have sequenced any new virus or disease. And that is now increasingly happening. Tanzania was a Marburg outbreak just last year. A community health worker had been trained through programs like USAID's and CDC's in partnership with the Tanzanian government to recognize when illness in a local community doesn't look right. And that a community health worker went to a home and found that there were 2 deaths and that they didn't make sense. They understood how to protect themselves and not get infected. They called in an emergency response, and there was someone at the other end of that phone who was there within 48 hours. There was a mobile lab that was brought in to collect samples that included, that USAID had funded. That allowed for capturing of samples, initially thought to be Ebola, transported to a CDC-backed laboratory that played a critical role in identifying it was Marburg disease, and enabled a response where the government drove the response. This was not, hundreds or thousands of people swarming in from around the world. The government led a response that shut it down within days. And this is happening again and again and again as these negotiations go along. So I think the critical thing to understand is that this work is already happening, it is ongoing, and the negotiations are learning and changing because of what we learn as financing arrives, new financing vehicles like $2 billion that Gavi has now for pandemic response that they did not have with COVID.
Right, great, thank you. Wow, well, I knew I needed more time for this panel. We're not even going to get to AI, which I was really excited to talk about. Let's end, that was a nice positive upswinging note. One thing that I wanted to ask really all three of you, if you could, 30 seconds, how do we find the political will that we need to make this stuff happen? It sounds like the desire's there. The mechanics are important, though, to get to Atul's point. You can't do it without the mechanics, even if there's the desire. I'm just curious if there's any, if what you've experienced this week helps you think about how you can pull together the political will to make these things happen and get folks on the same page. Maybe we could start with you, Atul.
Okay, I'll try and. There's 77 years now. This is the 77th meeting of the World Health Assembly, and during that time, the 50% of deaths in the world were occurring in children under 5 at the beginning of this story. Every year, there is difficulty reaching consensus. There are things we can get to consensus to, there are things we can't, and yet there is continued progress. And today, it is a world where, we are closing in on a 70-year life expectancy, almost double the global life expectancy. Health is the one space where the demonstration of the value of cooperation among nearly 200 member states creates value. And the sausage making is never pretty, and yet there is steady progress. I see it here. Just the fact that primary health care has now been accepted as a critical priority. 10 years ago, we were not there. And now we recognize that as the most valuable way to create value in the system.
Love it. A great point. Sonia, maybe we could go to you. Political will was something very important for Gavi, obviously, to manifest.
So my sense is that when you talk about political
Microphone,
will,
please.
I beg your pardon. My sense is that when you talk about political will, it's one thing to talk about an international agency. It's another thing to talk about a government. And if the frame of reference is a government, then as a former politician, I can tell you that you can only create political will by changing the framework of accountabilities. How many politicians, heads of states, and ministers have been held accountable for the loss of lives, for the children that die needlessly, for the mothers that die in childbirth, because their primary health care systems have hemorrhaging supply chains, are riddled with informal payments, and have primary health care systems that don't function? Unless you're going to make them accountable for outcomes in the social sector, things will not change for us.
Very good. Roland, you could probably teach a master class in political will after the past couple of weeks.
30 seconds, I think. But basically, I said it before, accept limitations, accept imperfections, and start working. I mean, what the colleagues already pointed out, we're not starting from scratch. A lot of things are just already in place. This is just building the framework around it and just start working instead of just emphasizing the differences between us. And that would be my main
focus on what is working. Agreed,
yes,
agreed.
Yes.
Well, thank you so much for your time. Roland Drees, Sonia Nishtar, Atul Gawande, please join me in thanking them. A wrap. Give me 2 minutes here, if I could please ask. You've been so patient. I must say one thing that I love about the healthcare audience. You're all sitting here looking at us, talking and absorbing and taking notes. There are very few of you buried in your phones. It's fascinating. Every other vertical that we cover at FP, we have everyone distracted and they're looking at something else. I just wanted to thank you all, and especially our distinguished speakers, for joining us. We are really grateful for your commitment to address these crucial global health challenges. Very importantly, I want to again thank our sponsors, OneSight, Essilor, Luxottica Foundation, Seed Global Health, Viatris, and McKinsey Global Health. Without their partnership, we would not be able to host an event like this, so that's really wonderful. And I want to thank all of you for being part of this important conversation. This is just one element in a stream of conversations that foreign policy holds on global health over the course of the year. We're going to be doing another version of our Global Health Forum at the UN General Assembly in New York in September. And that is really where a lot of the rubber hits the road. A lot of the focus there will be on AMR. We did a program on that a couple of weeks ago with IFPMA. We would love to see you all there if you are at UN General Assembly. And if you're interested in partnering with us, please see myself or my colleague Zach Wave. Everyone probably knows Zach. He's helped pull together this whole program. And we'd love to talk about how we can incorporate you into that program. Importantly, we are putting together a simulation, a crisis simulation on AMR. And we're looking for partners to help support that at UNGA. Really cool programs that the Maisha Alam, Dr. Alam, and Allison Carlson and the FP Analytics team pulled together on the ground. So please do talk to us about that. We'd like to do something similar around climate and health as well. So please do talk to us about that if you're interested. And then lastly, I want to mention, be sure to, I'm going to check my watch messages on this, I think. We have a podcast launching very shortly with Viv Health that we hope you will listen to. And I want to make sure I get the name right. Can We End Epidemics podcast. That's in partnership with Viv Healthcare, focused on HIV eradication. So please do listen to that. We do a lot of great stuff in the audio space and want to do more on health as well. And then lastly, I'd like to thank the amazing FP events team, Maggie Moore, Julie Espinoza, who I don't think is in the room. They did a fantastic job here and always bring their top game to all of these big forums and convenings. I hear the grumbling stomachs. Go eat. Good nutrition is important for good health. Thank you for paying attention.